Lord, and on Monday at the Paris conference, a great many people who have some skin in this game were there. And we want to make sure that we're talking to people who might have been outlined in that report as possibly providing arms, are being held to account, and that are part of the solution, because what we want to see is an end to the fighting as a precursor to a proper, well-organised international humanitarian aid programme, which will be at which the United Kingdom will be at the heart.
My Lords, that concludes oral questions for today. Motion for debate. The long-term sustainability of the National Health Service. Lord Patel.
My Lords.
You're going to wait.
It's not that bad that you should leave. It certainly emptied the House. I'm grateful and thank all the noble lords taking part in the debate today and look forward to their speeches, particularly that of the maiden speech of Noble Baroness Lady Ramsay of Wall Heath, and I wish her well. Several noble lords, Baroness Harding, Lord Stevens of Birmingham, Lord Darcy, Baroness Watkins, and the noble and gallant Lord Stirrup would have joined, but other commitments does not allow them to do so. I declare an interest. I'm a fellow of several medical royal colleges and faculties, but importantly, I worked for 39 years in the NHS and its glory days. My Lords, my comments today are based on comparing the current state of our healthcare system to 26 other systems that I looked at. They all have some problems, but compared to more developed systems of universal care in Europe and Far East, ours is severely strained. My Lords, on 26th April 2018, 6 years to the date, we debated the exact same motion. There were 50 speakers, and the debate lasted nearly 7 hours, interrupted by a statement on artificial intelligence. That, too, mentioned how AI will transform healthcare. Today's debate may well mirror the transcript of the debate 2018. So what has happened since then? We now have daily media reports of the demise of the NHS as we know it, and lots of suggestions on how to improve things. The public satisfaction with the NHS is at its lowest point. Waiting lists are at highest level. Waits at A&E are long and harming patients. Huge inequalities in health and poor outcomes. I could go on. After several organizations and reforms, a seismic one in 2012, NHS has not found the equilibrium it needs. But NHS is still capable of delivering superb care in primary, community, and hospital care. Thousands of hard-working, resourceful, and committed frontline professionals are prepared to go the extra mile despite feeling undervalued. They need to be better supported and valued before they too give up. It is the access to care that has become a major problem. My Lord's, current state of NHS is not because of some inevitable built-in decay. It is a system failure, results of decades of political short-termism, lack of long-term planning, underinvestment in capital, infrastructure, and technology. The system lacks capacity, with fewer beds, equipment such as CT, MRI, and PET scanners, with huge workforce shortages compared to other countries. We now have a workforce plan stretching to 2035 with no longer-term funding. We need it to work. And while I'm at it, I congratulate the noble Lord, the Minister, in getting 50,000 nurses in place, as they hope to. Lack of planning means disease diagnosed at a later stage, leading to poor outcomes. Modeling suggests that by 2040, 1 in 5 people will be living with major illness, upwards of 9 million people. Nearly 3 million people of working age will not be in work due to ill health. Not investing in health means greater pressure on budgets of other departments. Anxiety, depression, and chronic pain will be the main causes of ill health, which has implications for primary and community care. Unfortunately, my Lord, there is no silver bullet to reducing growth in people living with major illness in short to medium term. Diseases that affect millions, diabetes, cardiovascular disease, stroke, some cancers, chronic lung disease, are all amenable to either prevention or early detection. Focus needs to change to prevention and health, not just healthcare. From I am ill, I need to get better, to I don't want to be unwell. Countries that have recognized this are seeing the benefits of higher life expectancy and people living more years in good health and economically productive. The system needs to change to making primary and community care a central part of our care system. The current funding of primary care at 8.5% of the total NHS budget of 192 billion, lowest in 8 years, and employing only 154,000 of the 1.3 million workforce, will need to be significantly increased with a budget of at least 20% and more if we are to see access to primary care improve. The traditional system of a single portal of access to healthcare also needs to change. To enable patients to have greater choice of access will mean community care to be staffed by a multidisciplinary team of professionals, including general practitioners. Explosion in data will drive healthcare generated by patients and health system through screening services, early detection of markers of disease such as blood pressure and hypercholesterolemia, to mention but two. Population and risk-based genomic screening, liquid biopsies, individual health data monitoring, etc. will lead to early risk identification and detection of disease. Healthcare will be digitally driven, technologically enabled, personalized, and patient-centered. Patients will be involved in planning and managing their own health. The best health systems in the world have strong community care with a focus on helping people stay well. My lords, from birth to death, healthcare, and long-term care in old age is a continuum. In any part of it is not functioning, it affects the rest. Lack of a properly funded and organized social care is having a huge effect on NHS. 28 years of kicking the can down the road. After 7 policy papers, 6 consultations, 4 independent reviews, we have a social care system that is currently means-tested, needs-assessed, and underfunded. Lack of workforce plan of a service that needs 1.5 million people, with 2 million people still needing care, a third of whom get no support, and with a rise of 20% in working-age adults needing social care, it needs urgent attention. Capacity is getting worse, and public satisfaction with social care is as low as 13%. Various options have been considered: free personal care, DIL not cap, and universal care. The best performing comprehensive system of social care is provided in countries with a long-term care insurance or tax-funded, based on the principle of social solidarity. People above a certain pay range pay, throughout their lives. Without a solution to funding of social care, NHS cannot survive. Let me now, my lords, turn to the key issue of funding NHS. Funding of NHS has always been a roller coaster, despite its link to performance of the NHS. The planned budget of 24-25 is £192 billion, an increase in real terms of 0.6% from 23-24 settlement, but a reduction from 22-23. According to NHS England Finance Minister, it will provide an increase of 0.25% in spending. Over the parliamentary term from 1920 to 24-25, the increase has been 3% per year. But from 2010 to 2019, on average, it was 1.4%. Following the now famous expensive breakfast in 2000, when Tony Blair, the then Prime Minister, announced on breakfast television an uncosted commitment that he will bring NHS spending up to EU average. Following one less report, there followed a multi-year increase in funding, leading to better performance of the NHS. Waiting lists came down dramatically. Health inequalities began to improve. If EU average had been maintained in years that followed, budget would now be £40 billion higher per year. Lack of capital funding, an average of £2.5 billion per year from 2010 to 2019, has led to poor infrastructure and lack of equipment, and it hasn't increased. Rising costs have led to calls for reform of funding. Social insurance, some elements of self-pay, hypothecation, etc., have all been suggested. Each has its own problem. Analysis suggests that a single-payer system is most effective in costs and complexity. Public seem to prefer tax-funded system. What is important is that there is a properly costed long-term funding that tracks GDP growth. Also important to note is that while measures of prevention and healthy living may make people live longer in good health, it will not cut costs. If cutting costs is a priority, then a different model of care will be needed. But people may not live longer. In conclusion, my lords, a sustainable future with both NHS and social care is possible, and with it, a healthier population that leads to increased life expectancy and decreased health inequalities. It needs long-term funding commitment, including in capital funding, a strong primary and community care with a focus on prevention and health, digitally driven and connected, tech-enabled, and a clear plan with timelines of its introduction. Over-centralized, bureaucratic system will not address the fundamentals of an effective health care. It may well be, my lords, the last opportunity for an NHS as we know it and want. If not, public may well seek an alternative that could only lead to a two-tier system of care. So my question in this election year is to the noble Lord the Minister, and the same question to the noble lady, the opposition front bench. What plans do you have, each party have, to make the NHS sustainable in long term? And to the Liberal Democrats, front bench, what will you support to make amends to the part you played in the reforms of the coalition years?
Yeah, right.
My lords, I beg to move.
Yeah.
The question is that this motion be agreed to.
My Lords, I declare my interest as Chair of Genomics England and Oxford University Innovation and a board member of BioNTech, and it is a great pleasure to follow the noble Lord Patel. He is an eternal champion of the NHS, a great expert in these matters, and I'm grateful to him for convening today's important debate. Now, time is short, so I will focus on the role of genomic technologies in future-proofing the NHS. Now, from Crick, Watson and Franklin discovering the double helix structure to the Human Genome Project, the UK has long been at the forefront of genomic discovery. But with the 100,000 Genome Project, we did something quite different. We drove that discovery into the heart of the clinic for patient benefit. And today at Genomics England, we host the largest clinical whole genome dataset in the world. Now, recruitment of this cohort was complete in 2018, but analysis is still ongoing, and that increases the diagnostic yield all the time. In rare diseases, this is over 30% and rising, while in some individual conditions, like cystic renal disease, that's over 60%. And each of these diagnoses is a life changed. One 10-year-old girl, for example, was admitted into intensive care with a life-threatening condition, but it turned out she had been undiagnosed with a rare condition for over 7 years, with over 300 secondary care episodes, costing the NHS over £350,000 to date. It took whole genome sequencing to uncover a genetic deficiency and provide her and her family with a diagnosis at last, ending her diagnostic odyssey. And moreover, a bone marrow transplant proved curative. So from sequencing to treatment, in her case, cost £70,000. This is just 20% of her healthcare costs pre-diagnosis. Now, this sounds like an edge case, but rare disease patients have an average of 67 appointments over 75 months before diagnosis. For many patients, this diagnostic odyssey is much longer. So that is why Genomics England was founded, to use the power of genomics to do better. And our aim is to change the fundamentals of healthcare delivery. We want to create a virtuous cycle by making genomics routine in the NHS and support frontier genomic research and discovery to continually replenish one of the richest genomic data sets in the world. And in doing this, we will create a return for participants through better diagnostics and better therapeutics, a return from the NHS to boost productivity and efficiency through stratification, screening and early intervention, and a return for the UK by increasing R&D investment and clinical innovation. Genomics England now enables the NHS to deliver the world's first nationwide whole genome sequencing service for over 190 clinical conditions across rare disease and cancers, and this service has supported over 90,000 patients since its launch at the end of 2020, and that is scaling fast. We ask patients, moreover, for a specific consent to use their data for research purposes. Over 95% agree, and their data is stored in the National Genomics Research Library to enable cutting-edge research, and the findings of that are then driven back into the clinic to improve NHS care. This means that Genomics England structure is inherently translational by design. The heart of our mission is to drive long-term sustainable improvements in the care of our participants and the NHS as a whole. And we see research and clinical results flowing all the time. Research at Great Ormond Street for children with blood cancers found that whole genome sequencing was proven to provide additional information for diagnosis in 81% of cases. It changed the management of condition in 24% of cases. It reclassified diagnosis in 14% of cases. Meanwhile, baby Oliver in Cambridge was born with a 6-centimetre tumour on his leg. Under the microscope, this looked like an infantile fibrosarcoma. Standard testing was inconclusive, but with whole genome sequencing, it was confirmed as a benign myofibroma. This meant that baby Oliver was spared chemotherapy and surgery, and he is now happy and healthy. Now, we know that over the next decade, data, analytics and genomics will transform healthcare by enabling personalised medicine. This means more effective and tailored treatments, better diagnostics, and predicting disease susceptibility so that we can intervene earlier, possibly even preventing disease altogether. Earlier intervention and more targeted treatment, though, not only improve patient outcomes, they also reduce the huge healthcare costs of ineffective treatments and side effects. And multimodal genomic data that we're building now have the potential to cut the costs of drug development and improve population health management. That is why at Genomics England we've launched 3 programs designed to push the envelope of genomic medicine even further into the clinic. We're diversifying the ancestry of genomes to improve equitable outcomes for patients. We're validating long-read and multimodal cancer technologies to drive earlier and more accurate diagnostic for cancer patients. And our generation study, a newborn screening pilot, is designed to end the diagnostic odyssey where it starts and explore options for supporting genomic-enabled prevention. The potential of genomics is immense, but to fully harness its power, we must continue to invest in research, infrastructure and education in order to realise its full potential and truly make the NHS sustainable.
My Lords, I'm very grateful to Lord Patel for opening debate, and I very much welcome my noble friend Baroness Ramsay on her maiden speech occasion. My Lords, the noble Lord Patel talked about the NHS being severely constrained, but we know the NHS can work well. 14 years ago, the NHS was in rude health. New hospitals, new services, waiting times had come down dramatically. In 2010, the British Social Attitude Survey reached the highest level of satisfaction ever at over 70%. What has 14 years of coalition and Conservative governments brought us? Well, my Lords, the latest survey, published 3 weeks ago, recorded the lowest level of satisfaction since those surveys started in 1983 of 24%. Long waits have become the norm. Access to GPs, dentistry, CAMS services have become very difficult for many people. Ambulance waits are outside safety limits. Social care is unreformed. And as the noble Lord Patel said, we have very poor health outcomes as well. My Lords, if the NHS is to be sustained, it has to respond to health and care needs very different from those that existed in 1948. Complex, long-term conditions amongst a growing older population, yet the NHS at the moment seems woefully unprepared, or as Lord Patel said, it hasn't reached an equilibrium. So, my Lords, to turn this around, I agree with Lord Patel. First of all, we have to start upstream with a bolder preventative focus to reduce health inequalities and improve life expectancy. And as my noble friend Lord Filkin, Lord Bethel and others in their recent report, Health is Wealth, our nation's poor health damages lives, communities and our economy. Then major surgery is required of the NHS. Now, Wes Streeting has outlined a decade-long programme of modernisation with plans to digitise massive amounts of NHS paperwork and to make proper use of the NHS Act to give patients real control. And I do think what the noble Baroness said about genomics really fits into that model. But I also think 3 major changes need to accompany this. First of all, we need a step change from the current over-centralised and bureaucratic NHS. As Nigel Edwards of the Nuffield Trust has said, we have a culture of checking, assurance, performance management and other manifestations of a controlling and low-trust approach, alongside a system with a huge number of priorities. And I don't know if the Minister is aware how much NHS England's approach is despised and hated within the health service at the moment. And I would suggest that comes from the approach ministers are now taking to NHS England. It comes, my Lords, right from the top. Then this has to go with the workforce. We need a fundamental change in how we treat our people working in the NHS. Bullying, problems of recruitment, retention, morale, these are everywhere in our health service. And I've been really fascinated to read the outcome of a King's Fund, an RCN project entitled Follow Your Compassion, which looked at the experience of 22 newly qualified nurses and midwives. I mean, the work they do is high stakes with significant and often disproportionate responsibility that's placed upon them almost immediately after qualifying. Life, death and human suffering are everyday encounters, and the work of caregiving is demanding emotionally. But the overwhelming experience of participants were reported as feeling unprepared, anxious, silenced and exhausted. My Lords, you can have as many workforce plans as you like, but unless we get to grips with the way our people are treated in the health service, you will never really sort the workforce problems out. Now, finally, my Lords, we must invest in leadership and management of the NHS. And I remind the House I'm President of the Institute of Health Management. And like the military and many private organisations and companies, the NHS does almost nothing to select, nurture and develop the next generation of executive leaders. Training and development is often sporadic, and combined with lack of a systematic appraisal system, it makes development and deployment of key talent almost impossible. And the government's insistence on carving yet more managers out of the system at the moment is having a very, very damaging impact on their ability to take forward the kind of change that needs to happen. So, my Lords, if we don't sort this out, if we don't change the culture, if we don't put more trust in the NHS locally, if we don't sort out social care, all the other changes we need to make will come to very little. My Lords, this government has now had 14 years. They've had their opportunity. It's time for change.
My Lords, what a pleasure it is to follow the noble Lord Hunt of King's Heath, who is a former NHS manager like myself, and someone who clearly understands the difficulties and nuances of the future challenge of the NHS. And I'm also thankful to the noble Lord Patel for this very timely debate. The current performance of the NHS worries many and therefore needs to be improved urgently before it can be a stable, flat platform for us to raise to the challenges of the significant technological and demographic changes that will take place if it is become sustainable. The NHS's current performance is distressing to say the least, despite the gallant efforts of many staff within the system. People in need of care and treatment, unable to see an appropriate medic or professional, some waiting up to 3 years just to get on an NHS dentist list, people waiting in the back of ambulances outside A&E for hours, people waiting for a cancer diagnosis, not getting access to timely treatment which can be life-threatening, and people in great pain and agony waiting far too long for planned operations. The government has allowed this to happen and now tries to placate the public with a list of office-generated statistics and playing catch-up. It's not good enough. People deserve far better than this. But despite this appalling picture of failure by the government, this debate does make us think very carefully about the future of our NHS. My Lords, I'm sure the debate will be framed around two themes. One is how to make the NHS itself more productive, efficient and innovative, and the other theme will be the wider context of the demographic, economic and social issues in which the NHS will have to work. The reality, my Lords, is that both these themes will have to be addressed for a sustainable NHS. Today, time is limited, and so I can't go into depth what is required across both these themes, but I will throw these issues in as a starter for 10. The 1948 orthodoxy of which the NHS stands on has to be addressed if we're going to see an NHS that can meet future need. For instance, why do we have a fixed view of what a hospital should be, which is over 70 years old? Why are emergency and elective surgeries always in the same building? Is it time to think more laterally about emergency hospitals and elective hubs? The model of primary care needs to be questioned. Why the same model and front door system for over 70 years? This needs significant change, and from those who have significant primary care needs due to comorbidities and those who occasionally dip in and dip out of primary care. Maybe a different type of service delivery is required as the integrated electronic health record takes hold, no longer just one model of GP and primary care access. As technology, robotics, AI and data-driven services become central in the predicting, planning and delivery of healthcare, then appropriate leadership skills at all levels in the NHS will need to be addressed to maximise the potential of these issues as well as minimise the risks. And is it time to end the leadership model based predominantly on managing efficient siloed organisations, but moving to leaders who are experts in maximising health gain and facilitating community action to bring about complex change? Societal issues such as housing, education, the environment, of course, will have to be addressed, as the NHS doesn't work within a vacuum. A population that is ageing with comorbidities and the balance between the working age population and non-working age population, and of course climate change, need to be addressed. Some key issues that we need to think about is across government to support the NHS maximising health gain. I would suggest supporting people to age with dignity and independence, tackling deep-rooted worklessness, and an absolute laser-sharp determination to narrow the health inequalities, as well as having a long-term, fully understood funding formula for both the NHS and social care. This will take long-term and focused action by government and society. I'm not sure if the siloed structure of central government can deal with these challenges effectively at present. The approach must be a community health-based model to maximise healthiness and and to increase health outcomes. One simple way, my lords, of supporting this is for the Treasury to set up designated funds that can be used in communities and the NHS to invest for health. It will break down the problem of pretending you can move existing NHS budgets that are mainly sunk fixed costs into prevention to help reduce health inequalities. Talking of funds, as the Noble Lord Patel has said, it's vital that once and for all we sort out the social care crisis. The NHS can never be sustainable as a nation we haven't dealt with how to deal with social care funding. After the general election, I think it is a duty of all politicians of all parties to sit round and work out a cross-party solution to this difficult problem that has been left for far too long. My lords, I just feel that we need to take a different approach and think about some fundamental questions if we are to have a sustainable NHS.
I congratulate my noble friend for his excellent speech that introduced this debate. I'm also very much looking forward to the noble lady Baroness Ramsay of Wall Heath's maiden speech and bringing her great expertise to bear on this issue. Can I also declare an interest, I suppose, as a former chief executive of the NHS in England and permanent secretary of the Department of Health between 2000 and 2006, when I had the privilege to work with three noble lords who are taking part in this debate, Lord Reid of Cardoan, as Secretary of State, and then successively Lord Hunt of King's Heath and Lord Warner in your Lordship's house. I want to make 3 points about major reforms that are required and a fourth point about implementation. I'm going to state them briefly at the beginning in case I run out of time. So the 3 reforms I'm talking about are following very much from where Lord Scriven was just talking about. We are using a 20th century model of service delivery for 21st century issues, and that must change. The second point is that government needs to create a cross-sector wide health and care strategy and plans, of which the NHS is part. And thirdly, it needs to be underpinned by changes to professional education. It's fundamental, not yet been mentioned, but I'd like to say something about that. And finally, implementation needs to be based around a shared vision that motivates and involves people and efforts to build consensus and momentum. I would also just say that in passing that I've very much enjoyed the Noble Lord and Noble Lady Baroness Blackwood's speech. I think it's fantastically important, and I know that Lord Bethell and others will be talking about the links between health and prosperity. A healthy workforce and a prosperous country is fundamental. The first major reform I'm talking about is we need to change the model with much more focus on primary and community care, support for carers and social care, and action by many people, not just the same model. It's not just a question of more GPs and nurses. We see around the country now community health workers doing outreach. We see the great programme of Growing Health Together in Surrey. We see people creating the future, and we need to build on those examples for what a new model of primary and community-based care will be. The second major reform, I've spoken many times in the House about the African saying, health is made at home, hospitals are for repairs, and indeed have also been pressing the case for quality standards to have healthy homes. The NHS is dealing with many problems that it has not caused, and they need to be addressed at source. There needs to be a government cross-section health strategy and plan of which NHS and social care is a part. And I would suggest that plan needs to focus on, the aim must be to create a healthy and health-creating society. And indeed a prosperous society while we're at it. And that's a focus not just dealing on the problems by tackling things like air pollution, but also creating the conditions for people to be healthy. And think of Sure Start, for example, that I know many noble lords will be aware of. This is actually creating the conditions for people to be healthy. And that's why I think we should be looking here at health being about health care, prevention of disease, but also promotion of the causes of health and creating the conditions. The third major reform underpinning all this is a need to transform professional education. I'm happy to be associated with a radical group of young professionals who are starting to drive this agenda, recognising they will need different skills for the sort of model that I'm talking about, as well as retaining the basic science. Finally, implementation. My experience as Chief Executive is I was lucky to arrive at a point of Chief Executive with two things that had happened. Firstly, the government of the day had brought people together to create a plan. They built energy and they built hope, and there isn't much energy and hope around today. And that hope and energy created goodwill that carried us forward 2 or 3 years. That goodwill lasted a really long time and allowed us to make radical changes, including bringing in the private sector and other things. It's very much harder today, obviously, but, you know, as already been mentioned by the Noble Lord Hunt, by the end of 2005, waiting lists were below 1 million and a 6-month maximum wait, and there was more improvement to come from then on. Very much harder today. The NHS is in worse condition, although there is still good care being provided, as the Noble Lord Patel has emphasised. And there must be, but we must do something, or the new government coming in, another government coming in, this government continuing, needs to bring people together around this problem and to create a solution that people will buy into. But we must also deal with the presenting problem. We can't just deal with the long term. We've got a new government coming in would have to look at the waiting list and how to handle that. But it must then pivot to health. I believe that 20 years ago we talked about dealing with the issues that people were presented with, waiting lists, A&E, and then we would then focus and pivot to health. We never quite pivoted to health. The time now is to change from talking about healthcare to talking about health, which embraces healthcare, but also prevention and the creation of health.
My Lords, it's a pleasure to follow the Noble Lord Crisp, and I thank the Noble Lord Patel for providing this opportunity to consider this challenging but vital issue, and I look forward to the maiden speech of my noble friend and colleague, Baroness Ramsay of Wall Heath. My Lords, I'd like to focus my remarks on care needs and highlight the crucial interdependence of care and the NHS, and draw on my experience as a member of this House's Select Committee on Adult Social Care, so ably and empathetically chaired by my noble friend Baroness Andrews. Report A Gloriously Ordinary Life was published at the end of 2022. It's clear to me that if we're to ensure the long-term ability of the NHS to deliver comprehensive healthcare for all, adult social care is crucial. Fundamental changes to social care funding and provision in the form of a national long-term plan for adult social care is a national imperative. We engage with the NHS at all levels in our lives, but adult social care is often invisible and off the public agenda until we have a sudden need for it. Yet, as our report noted, 10 million of us are affected by it at any one time, either because we receive care and support or because we provide paid or unpaid care. And because we're living longer and with more complex conditions, we're all increasingly likely to be one day included in that number. Noble Lords will be aware that there's no national government budget for adult social care in England. Services are financed primarily through local authorities, bolstered by large numbers of people who fully or partly fund their own care. As the APPG on adult social care highlights in its recent report, Future of Care 5, this piecemeal approach means that social care is particularly vulnerable and will often be the first to lose out when, and I say that advisedly, when the NHS or local authorities have their budgets cut. The 29% cut in local government funding since 2010 has led to an estimated 12% drop in spending per person on adult social care services. If we're looking at new models of care and systems of care and funding within the NHS, we have to change short-term emergency funding. Social care needs a long-term funding plan. As our Select Committee highlighted, improving adult social care should be seen not only as an investment in the NHS, but in ourselves as a resilient and caring society. As the quality and consistency of services has suffered, so has the pressure and demand on unpaid carers risen. Estimates suggest that there are more than 6 million unpaid carers in the UK. The actual figure is likely to be much higher. Estimates of the value of unpaid care provided by family and friends vary between £100 billion and £132 billion a year. My Lords, that's an extraordinary contribution to the health of this country, and it really does need to seem to be valued. But as one carer who gave evidence to our report told us, unpaid carers are often not even considered to be part of the health sector, and yet without them, the sector would collapse. Despite their numbers, carers feel invisible, many of them at financial, emotional and physical breaking point. Hearing the lived experiences of those who gave evidence to the Select Committee was sobering, at times even harrowing. Time and again they told us of being unaware of what help was available, not knowing who to ask or how to access help, or not being listened to, of being put through tick box exercises that bore no relation to their actual circumstances or needs. Time and again, these carers were falling between the gaps of a broken system, often over many years. One parent carer told us that while her daughter was under the age of 18, she had a central point of contact within the NHS, a paediatrician, who could project manage the different strands of specialism her daughter needed. But once her daughter was 18, all this fell off a cliff. The distinction made between a health need and a social care need meant unpaid carers, often family members, are on their own, battling to get both information and help. My Lords, in the Select Committee report, we urged the Government to establish a Commissioner for Care and Support who would be able to raise the profile of social care, act as a champion for older adults and disabled people and unpaid carers, and accelerate a more accessible adult social care system. This recommendation sadly gained no traction with the Government. But in light of the overwhelming body of evidence on the need to improve adult social care and advocate for those at the heart of adult social care of all ages, can the Minister give us any assurance that this will be revisited?
Lords, and I'm most grateful to the Noble Lady because she was just before the 5 minutes, but the Noble Lady is the only one, and the Noble Lord Seeker's excellent speech was 2 minutes before his allotted time. So just a gentle reminder to all Noble Lords to keep their allotted time of 5 minutes, and I know that the next Noble Lord, the Speaker, will keep to that because he's a perfect timekeeper. Thank you.
Always. Well, it's a great privilege to speak after Baroness Warwick, and I'd like to thank my good friend Lord Patel for bringing about this important debate. In terms of my own declaration, I'm a research fellow at the Milken Institute on Public Health, a research fellow at King's College London on biodefence, and chairman of Business for Health, the community interest company that advocates for greater involvement in health by businesses. My Lords, there is so much and so many powerful words about the importance of investing in our healthcare system, and I saw at first hand the incredible power of our national health system during the pandemic, and very much literally love the system and what it does for our society. But we can't duck, I think, two particularly important issues when we are debating this key issue. One is the unbelievably heavy cost on society of our healthcare system. The Deputy Chairman, Wal Kalade, who many will know, asked it very bluntly. When he joined the board, it was 100 billion a year. It's now edging towards 200 billion a year. And he's asking, where the hell does it all stop? And my Lords, I think that is a pertinent question to this debate, because we can't treat our way out of disease. We cannot treat our way into good health. We have to look at the underlying health of the country and look at how we prevent disease. And we also have to think about the return on investment of our own healthcare system. If we want to sustain it and ask for it to be in a secure financial position, we have to ask, is it giving a return on investment? We have 2.8 million people on long-term ill at the moment. 500,000 extra have left active employment. And the OBR predict there's no hope that they're going to return, and there may well be another 500,000 on the way out in the next year or so. So if the prosperity of the country, both economic and spiritual, is not being underpinned by our healthcare system, then we do have to wonder whether, as a number of noble lords have pointed out, whether we have to have a bit of a rethink. And that's why, alongside noble Lord Filkin and other colleagues, I launched Health is Wealth, a fast start for a covenant of health. And we prioritised 5 areas of prevention, which I believe are achievable, affordable, and will yield a massive economic benefit. Firstly, we have to scale up and deliver on our ability to detect and address the risk factors of disease. And I'm grateful for my noble friend Baroness Blackwood for her words on genomics. Secondly, we have to strive for a smoke-free Britain. We should all celebrate this week's achievement on the smoke-free generation legislation. But, my lords, there's so much more we can do in the next 10 years to reduce the 5 million people who are already smoking. Thirdly, we need to build much stronger focus on healthy eating, making it affordable for all and helping us to reverse the upward trend on obesity. Fourthly, we have to focus on the health of our children, ensuring that healthy habits are ingrained from an early age. And I would emphasise mental health here, and in particular the role of the digital world in provoking a mental health challenge for our young people. And finally, we need to ensure that no area is left behind, and we need to look at helping those who live in areas of the worst health to live longer. And that includes the underlying environment in which they live, the dirty air, the mouldy homes, the online and toxic workplaces in which they work. My lords, the moral argument for this focus on prevention and upstream focus is very, very strong. But the economic argument is absolutely overwhelming. We cannot keep pouring increasing amounts of money into more hospitals, more doctors, more nurses, and more medicines in the hope that we can treat our way out of this problem. We do have to address the determinants of health. And I would like to ask the Minister very much what more can be done in this space from a position of ambition for the NHS. We can't keep scapegoating the NHS for the poor health of our country. We do have to look upstream and focus on the determinants of health.
My Lords, it's a very great pleasure to follow the noble Lord Bethell, and in particular to congratulate my noble friend Lord Patel for the very thoughtful way in which he's introduced this important debate. In so doing, I declare my own interests as in the Register, and in particular that I serve as Chairman of the King's Fund and Chairman of King's Health Partners. The noble Lord Patel alluded to the report of your Lordship's House Ad Hoc Select Committee on the long-term sustainability of health and care, published in April of 2017, and His Majesty's Government responded in February of 2018. The debate to which the noble Lord referred covered extensively questions raised in that particular report and the government's response. But very little has changed, regrettably, since then. Of course, it must be recognised we have had the global pandemic, acute health emergency, many other challenges. But the reality of the situation is we have not been able to address in any meaningful measure either acute or mid-term challenges with regard to the sustained delivery of health and care in our country, nor indeed have had even initiated a meaningful approach towards the long-term sustainability question for health and care in our country. And we've heard in this important debate that performance, regrettably, is not where it should be in terms of clinical outcomes. It's well recognised and genuinely sought after by all parties and all constituencies that we improve clinical outcomes. Outcomes are not as good as modern medicine would predict and could be delivered. Operational delivery is poor, and the trajectory for operational delivery in the NHS does not appear to be improving. When we look at the question of workforce, we've found it impossible to inspire and motivate the healthcare professionals, be they clinicians, nurses, other healthcare professionals, to remain committed to the NHS and to be inspired not only to serve,
but to innovate, to undertake research, and to ensure that the application of that research and innovation is quickly brought to bear for the benefit of patients. And then more broadly, the research and innovation agenda, which our country has led for so many decades, appears to be falling behind. And without that agenda being centre-positioned, sustainable healthcare in our country will not be achieved. That's not to say that there haven't been many important initiatives over decades, very well-meaning, both to address acute problems and to try and address longer-term sustainability issues. But they have not delivered. And as a result of that, we have to ask the question, how are we actually going to achieve a position where we can develop a national consensus, where we can bring together diverse constituencies, political, public, professional, with a common understanding and a common vision for the future, appropriately motivated, understanding that what is proposed is actually deliverable, and what is proposed remains a deep-seated national commitment across political divide. Part of the problem may be that questions with regard to the medium-term or long-term sustainability of health and care in our country are projected and considered in the lens of either a clinical problem, a delivery problem, an innovation problem, rather than looking more holistically at all of those issues, some of which were addressed in the previous NHS long-term plan, but more broadly in the broader context of the economy of our country, of other policies such as immigration that need to be coordinated with a broader understanding of the needs for the delivery of healthcare if we are to have a sustainable long-term plan. I'd like to ask the Noble Lord Minister, in fact, follow the fine example of my noble friend Lord Patel and ask Baroness Maiden as well, and indeed the Liberal benches, what approach are they going to take for the national interest now to achieve a consensus across the needs for the delivery of health and care in our country? How is this consensus to be delivered? In the debate on the Noble Lord's report in 2018, the idea of a Royal Commission was dismissed as something that was not politically acceptable and would not deliver in a short enough time frame. But 6 years have passed since that debate. In that 6-year period, maybe something like a commission would have delivered the answer. But it is now essential we develop a clear consensus and have the courage to adopt a long-term plan addressing the holistic needs beyond the question of clinical care alone.
My Lords, thank you for the opportunity to give my maiden speech today. Let me start by thanking Lord Patel for the opportunity to speak in this important debate, and to noble lords on all sides of the House who have made me feel so warmly welcome, and to Black Rod, who actually knows where Wallheath is, without any explanation, her staff, the doorkeepers, and many others who have been so supportive and informative, helping me on a daily basis to find my way around this beautiful building. I am also grateful to my noble friends Baroness Hayman and Lord Faulkner for introducing me, and to Baroness Pickleathy, who insisted that my 9th day in this House was the right time for me to give my maiden speech. When I got the news that I was to be nominated for a peerage, my first words were unrepeatable for Hansard. My second were regret that my father and mother were no longer alive to witness this amazing honour and privilege. They were Lancastrians, children of men who worked down the pit, from a long line of proud trade unionists and co-op members. My mother wished all her life that she had had the opportunity to gain educational qualifications, but she had to leave school at 14 and then work to pay the doctor's bills because her own mother was dying of stomach cancer just before the introduction of the NHS. My lifelong personal interest in the NHS was originally driven by the life experiences of my older sister Patricia, who died 6 years ago. Patricia was born in the 1950s with what we now call learning or intellectual disabilities. But at the time, she was labelled first as mentally defective, then mentally handicapped, and she was also physically disabled. She lived from childhood until the 1980s in a huge, forbidding mental hospital in the West Midlands that I was scared to visit as a little girl and teenager. As the years went on and the NHS evolved, she moved into the community, into a house with others, and we could visit her without having to ask for permission and become involved in her medical and personal care. I became her co-guardian after our father's death. I have inherited my mother's lifelong gratitude to all those who work for the NHS, not least those in the hospital opposite this place, St Thomas's, where 2 of my children were born and 3 have been patients, one with a life-threatening peanut allergy, another with severe childhood asthma. And over time, my personal commitment to the NHS broadened into the professional. I was appointed chair of Lambeth Primary Care Trust just over the river and relished the opportunity to work in partnership with GPs and others to try and make a real difference to local people's lives, for example, by helping to reduce teenage pregnancy and smoking rates. I then joined the board and became vice chair of UCLH in London, where my youngest child was born. And in 2016, I was honoured to be appointed the chair of Cambridge University Hospitals, otherwise known as Adam Brooks. There, I was privileged to work with some of the world's most distinguished doctors and biomedical scientists, whose commitment to groundbreaking research was matched only by their determination to see the results implemented to the benefit of the public at large, truly medical research from bench to bedside. Whatever comes next for the NHS, it is clear that when it is properly funded, as the noble Lord Stevens of Birmingham fought hard for in challenging economic circumstances, its people do wonderful work. This is particularly true when doctors, nurses and other health professionals, both in and out of hospitals, as well as those in public health, work truly collaboratively to help our growing and older population stay in good health for as long as possible. In my experience, structural reorganisations designed, however well-meaningly, to try and achieve improvements are trumped every time by positive relationships between clinicians, managers, patients and the public, supported by the right level of funding in the right place at the right time. And this is just as true for the NHS's engagement with other public services. We are all kept as healthy as possible and taxpayers' money is well spent when the NHS, local government, housing associations and schools work in partnership to support adults and young people with chronic and challenging conditions. The NHS's continuous commitment to finding new methods of care in partnership with others improved my sister's life immeasurably over the years, and free healthcare available to all who need it at the point of delivery seemed like the best thing a government could offer its citizens to my mother as she paid those bills long after her mother died. She was right, and said so repeatedly as my father, 40 years later, was being treated for lung cancer. The NHS care he was able to get at home from GPs and district nurses was literally unaffordable to my poor grandmother. I am grateful to have been able to contribute to this important debate today, as well as to hear and learn from so many distinguished noble lords. I look forward to many more excellent, informed and expert debates in this House, listening carefully to everybody, which this House is famous for.
My Lords, it is an honour and pleasure to follow my noble friend Lady Ramsay and to be the first to congratulate her on her truly memorable maiden speech. I should not be surprised that she's made a remarkable speech because she is a remarkable person who brings a wealth of experience and achievement in public service to your Lordship's House. As a barrister working in local authorities, as chair and non-exec on many health agencies, and as an upholder of standards in public life, she has already achieved a great deal. Indeed, the range and breadth of her experience is so great that she could have made her first contribution in a variety of debates. I'm sure your Lordships will be glad that she chose this one. As we've heard, she brings willingness, commitment and enthusiasm to continuing her work in this latest phase of her public service. Her colleagues on these benches and throughout your Lordship's House will be grateful for her presence and look forward to many more memorable contributions. My Lords, I offer my thanks to Lord Patel for this debate and for his indefatigable pursuit of improvements in health and social care. Like many noble colleagues, I could give you examples of where great care is happening, and my own recent experience could not be improved. The use of technology to make appointments and to deliver care was fantastic, as was the skill and understanding of all the professionals with whom I came into contact. But too often, patients report very differently. As we know, 24% satisfaction with the NHS is nothing to be proud of. My Lords, I have lost count of the number of health debates in which I've taken part in my 27 years in your Lordship's House, and in every one, there's always been agreement about what is needed to provide that comprehensive and timely care which we seek. We always agree about two things. First, we need more preventive service, as Lord Patel and others have reminded us. We treat people too late. We allow their conditions to become chronic, so that major interventions are needed when small ones would have sufficed. And we don't treat the broader picture. We don't look at the lifestyle issues and the diets which cause the conditions, and the poverty which is the reason why people eat the wrong food, and which in turn cause diabetes, the need for new joints, the disabilities which mean people cannot work or have a tolerable, pain-free life. Still less do we think of surveying living conditions, putting in a handrail and getting rid of the rugs which cause falls, which in turn create huge amounts of work for the NHS and huge amounts of distress for an older individual. And the second area where we've always agreed, my Lords, is that we need more integration. I shall have more to say to your Lordship's House next month when the report of my committee on integration in primary and community care is debated. But let me just agree currently with noble lords that the NHS allocates an excessive amount of funding to reactive hospital care at the expense of preventive primary and community care. This was not just the conclusion of my committee, but was the strong opinion expressed by all the former health ministers and secretaries of state who gave evidence to the committee. They were from different parties and ministers in different circumstances, but they were all adamant on this point, as will many noble lords be in this debate today. And of course, this mismatch in the levels of funding and importance is so clear in the NHS is even more significant when it comes to social care. We are all victims of the historical accident, which means that local authorities fund social care. Nobody knew we would live so long and have so much need for support in 1948. But we have made only pathetic attempts or failed attempts to rectify this situation. I know the Minister would not call the Better Care Fund either pathetic or failed, but it is at best a sticking plaster to cover the basic flaw in our funding system. Unless we get better integration between health and social care, we will never deliver comprehensive care, and the divide will continue. In order to get that divide addressed, we have to address the join between the NHS and local authority, and where professional silos and the arrogance which goes with such divides has not been addressed and still needs to be eradicated. We never seem to have found the ability to translate local success into national guidelines. And the not invented here syndrome stymies all attempts at change. And don't get me started, my lords, on the main providers of both health and care, and I'm grateful to Baroness Warwick for her mention of the unpaid carers. It's not the NHS or local authorities, but the family carers who provide willingly and with love billions and billions. Estimates vary, but it's well over 150 billion, the cost of a second NHS. Doesn't it make sound economics as well as moral good sense to support them? To support them better than we have ever succeeded in doing. They are the best value service any nation could want. Yet what do we hear? Carers being prosecuted, even persecuted, for inadvertently going £1 over the earnings limit on the derisory amount of the carers' allowance. We hear of carers being forced to abandon paid employment, building up future poverty for themselves and future liabilities for the state. We hear of carers being ignored, their skills, knowledge and experience being dismissed, not being consulted, their own health needs going unrecognised. Carers are and will continue to be the bedrock of health and care services, and I hope the Minister will confirm the importance of recognising this.
My Lords, I declare my interest as an NHS consultant and chair of the Bevan Commission. And I congratulate the very moving speech of the noble lady Baroness Ramsay of Wall Heath, and for her reminding us of the hardship of the pre-NHS days and why the NHS is so important to us. The noble Lord Patel's contribution opening this important debate was characteristic of his great contributions. My Lords, I had the pleasure of being a member of the Times Health Commission, and we were given the task of suggesting reforms to improve the NHS. It was a very interesting experience, taking evidence from a wide range of people, including previous ministers. At the end of our deliberations, we came up with a 10-point plan for health, which I would like to outline briefly now. For patients, it's clear that digital health accounts, such as patient passports, accessed through the NHS app, are crucially important for the future. Patients need to be able to coordinate their appointments, manage any medication, and view their own records in full. We cannot expect people to take control of their own health if they don't have their test results, referral letters, vaccination and intervention records, and the ability to review in their own time the outcome from different consultations. Patients retain a small percentage of what they're told in a consultation, so it's very important people can review things in their own time and review it with their families. In Wales, we established Talk CPR to address the very important conversations around end of life and resuscitation procedures that establish whether somebody wants ongoing treatment and intervention or not. We found that by giving patients video books to take home, they were much more comfortable discussing issues than trying to have all of that discussion in the context of a short consultation. In the Times Commission, we focused on the workforce, the need to reform the GP contract, write off student loans for people who continue to work in the NHS rather than leaving it, and the importance of a no-blame compensation approach to errors rather than the current blame culture which demoralises. We address the need for mental health support and tackling obesity in particular. It is a precursor to so much disease, and the antecedents of illness can be decades before a patient presents. The importance of research and investing in research became more and more evident. Data collection is crucial for us to monitor and understand better the course of health in our own country, but also as a basis for inward investment from pharmaceutical and technological innovators. The NHS could be a major testbed with integrated information and fast-track processes to attract and retain researchers from around the world with inward investment. But unless we speed up the processes for investment, we will never reach our goals. One of our recommendations was to have a Healthy Lives Committee to look at the impact of improved public health and a healthy life expectancy, addressing the antecedents of poor health. But whatever we do, bad things happen. People have accidents, severe illness hits out the blue, new infections emerge. Although palliative care is now in legislation as a core service, contracting is not ensuring patients have access, yet it's cost-effective to involve palliative care services early. We need a national funding formula to support integrated care boards in establishing contracts with palliative care providers. Services must be rapidly responsive 7 days a week. Without that, the sad toll of inappropriate transfers to emergency departments out of hours will not decrease. In recovery from a serious accident or devastating illness, rehabilitation early becomes crucial to improve outcomes and decrease costs. Next Monday, I'm hosting a drop-in on rehabilitation with a full range of professionals involved. Rehabilitation is cost-effective for the NHS, yet, like palliative care and hospice services, it's very patchy in provision, and so we allow distress and ongoing avoidable morbidity to accumulate and jeopardise long-term outcomes, both in the patient and in the bereaved. Fair access to help in response to need is essential. We must never forget the patient.
congratulations to Baroness Ramsay for a very moving and brilliant speech. I also want to thank my noble friend Lord Patel for bringing this timely debate today. As my noble friend mentioned, the importance and vital role that community is going to play in future sustainability of the NHS. So, my lords, I want to speak briefly on community nurses, and they deliver, along with the help of care assistants and families, bespoke care to individuals in their homes and community. It is not unusual for these professionals to be living in the area where they carry out their work, leading to, and I feel this is a key point, having the added advantage of often being aware of the family circumstances, bringing the continuation of information, relationships and management, fostering an organic connection for patients and their families, care that is delivered to the community from birth to death. My lords, we all know that primary prevention avoids the manifestation of disease, improving health through information and lifestyle behaviour, which includes dietary and nutritious interventions, along with vaccination strategies to promote sexual reproductive health, along with family planning and mental health well-being. And if this healthcare can be provided in the community, in family hubs, schools, the workplace, medical centres and homes, it obviously frees up hospital beds and unnecessary GP appointments. Yet, from what I have read, 4,000 district nurses are providing care for a population of around 55.8 million, one nurse to every 14,000 people, whereas there's one GP to 1,600 people. I believe the fall since 2010 equates to almost half of NHS community matrons and district nurses and 29% of health visitors. Health equality is achieved when everyone has a fair and just opportunity to be as healthy as possible, and community-based nurses are well positioned to play an important place in addressing the underlying causes of poor health. We are all well aware that it is vital we move from concentrating solely on treatment and management of disease to prevention and social needs. Embedded within the community, community professionals are well positioned to build trust. They see firsthand the limitations associated with those they are involved with, be it housing, family, mobility, transportation and dietary issues, to mention just a few. They connect and engage with partners from across social health and other services. That's the ideal, but without the professional numbers required to carry out the vital work and giving them time with their clients, along with time to report back to the multidisciplinary team, none of the above can be achieved. It is an attractive career, and with flexible working, diversity of roles, and being an autonomous and independent practitioner with the use of modern technology. There should be a productive time with clients and less paperwork. But a survey done by the Queen's Nursing Institute in 2022 found, and I quote, "the application of digital technology in practice is poor." The survey pointed out that poor user experience appeared to be around design and function rather than lack of computer literacy and enthusiasm. It went on to highlight problems with unsuitable hardware and software, lack of integration and repetition data entry, as well as lack of compatibility between different computer systems. Disappointing. Can my noble friend the Minister tell us what has been done in this regard, and also what has been done to up the level of community nurses, encouraging nurses to go into the particular genre of nursing? So to conclude, we have heard over the past few weeks there is a record fallout of the workforce due to long-term illness. Community nursing enables patients to remain independent in their homes with bespoke care, which is obviously beneficial to their health, economically beneficial to the NHS, and beneficial to productivity of the country. My lords, this has been rather rattled through, but as with sustainability with the NHS, time is of an essence, and it's the same within this chamber.
My lords, congratulations to Baroness Ramsay on her excellent initial contribution to our debates. My Lords, unlike Lord Patel, my experience is that too many interests are still worshipping at a 75-year-old NHS shrine that only 25% of the population is satisfied with. The NHS is trapped, if I may say so, in an over-centralised management and service delivery model that cannot improve efficiency fast enough to cope with the tighter funding it faces. Too many services, as others have said, are delivered through what I would describe as overcrowded, expensive and overprotected acute hospitals. We have neglected investment in primary care, community health services, social care and public health. We should ignore pleas to pour more money into this dysfunctional 75-year-old and focus on fundamental reform led by people capable of delivering change at pace. My sketch of a 5 to 10 year operational plan to do this has 5 main strands. First, fundamental change of a failing top management at the Department of Health and Social Care and their replacement with a new Health and Care Management Board chaired by the Health Secretary and with a CEO with high-level management experience outside the NHS, supported by a Chief People's Officer on all workforce issues and a Chief Finance and Efficiency Officer. I won't go into more details, but what I think this would lead to is the abolition of NHS England, which will get quite a few cheers, I suspect, in the NHS, and some other health quangos, which will get a further lot of cheers. Second, I think we should consider emulating Singapore, which has similar health outcomes to the UK, while spending less than 5% of its GDP on health. This low figure is accomplished because it delivers so many services outside acute hospitals using up-to-date technology. It is very difficult to get into an acute hospital in Singapore, my lords. To achieve this change, we need to restrict the proportion of NHS funding going to acute hospitals over a 5 to 10 year period and invest much more in community-based services. We would need a clinically led national team, perhaps using the Academy of Medical Royal Colleges, to concentrate more specialist services on fewer sites, but with an enhanced capital investment programme for selected hospitals. Those hospitals with fewer services should become local community hospitals, and this should be the end of the District General Hospital, a 1960s model. To make these changes stick, they should be underpinned by secondary legislation. Third, my lords, in consultation with the Royal College of Surgeons, all elective surgery to be undertaken in their own units, either provided by the NHS or contracted for with the private sector at NHS prices, which we managed to achieve, I have to say, in the noughties. Again, a capped 5-year budget not used for other purposes. Fourth, devolving responsibility for the management of all GP contracts, primary care, community health, social care and public health to new regional bodies with elected mayors heading up as many bodies as possible using devolution deals like that done in Manchester. There should be a protected budget for this sector, growing faster than the acute hospital budgets, with any real terms cuts reported to the Public Accounts Committee. And fifth and last, a statutory proportion of the NHS budget should be devoted to public health, administered under the guidance of a new independent Office of Public Health, set up on the lines of the Office of Budget Responsibility. They are able to take the kind of difficult decisions on public health that I think the experience of recent years suggests elected politicians find very difficult. My lords, this I would call the tough love approach, and I think it is the direction of travel that the NHS needs to consider taking. And if the front benches want to find out more, they can go to the Social Market Foundation website and read my pamphlet on the NHS at 75.
My Lords, congratulations to Baroness Ramsay and thanks to Lord Patel, not only for securing debate, but also his sweeping overview of the coming years. I have a much more modest aim. I would just like to tackle one issue, which is the 7.5 million people who are on the waiting list, suffering sometimes pain and very often distress, and to look at the reforms to the NHS of the years 2000 to 2005 and how it tackled that. There are a number of ministers in the House, former ministers in the House, and they will be well aware that think tanks very rarely look back with kindness and positivity towards our efforts. I was therefore somewhat surprised and pleased that the King's Fund report of 2022, Strategies to Reduce Waiting Times, was unusually positive. Indeed, it argues that some of the NHS reforms I was involved in, along with Lord Crisp and Lord Warner, actually worked, which is a first, I think, for think tanks' reviews of ministerial activity. It states, with the overall judgment, that the years following the NHS 2000 plan provided important lessons for tackling long waits successfully. I suggest, therefore, that we might look at some of the levers that we used because we've got so many people waiting in pain and distress, as I said at the moment. And the simple judgment of that report is important because it means that we don't need to be fatalistic about the large number of people waiting in care. We've faced the issue before, and as a nation we succeeded in solving it. So let's just briefly mention the reform levers which the government might want to consider or to enhance. From 2002, we developed the policy of paying NHS trusts more money if they carried out more work. Put like that, it sounds very simple, but at the time it was portrayed as an extremely controversial right-wing point of view. Ironically, from some of the same people who naturally assumed that if they produced more at work, they would get paid more, but they felt somehow it was wrong for NHS entities to work on that basis. They argued at the time that it would undermine the NHS. It didn't. It acted as a clear incentive to do more work, and because more work get carried out, waiting lists, among other things, began to fall. Second, we realised there was no point in providing an incentive to a trust to obtain more resource by carrying out more work if at the year end the trust had to give back any surplus to the centre. That's why in 2004 we created foundation trusts who could roll forward the resources they made and reinvest them. Again, arguing for this caused many to attack the government at the time for being too right-wing. Thirdly, from 2002, we started to offer patient choice to those who had been waiting for more than 6 months. And I was told at the time, as was my predecessor, Alan Milburn, this was no use because patients didn't have the knowledge, the ability, the capacity to exercise that choice. Well, funnily enough, of course, that was again proved wrong because rather than wait longer, most patients chose to go somewhere else than their local hospital, despite the disadvantages of travel, because they valued the short time before treatment. Fourth, the money followed that patient choice, putting patients, not providers of health care, in the driving seat and rewarding those carers who best meet patients' needs and satisfactions. And fifthly, we not only used the private sector to provide services for NHS patients, but we also created, through the independent sector treatment centres, a new form of private sector that increased productivity by each concentrating on one form of treatment. So taken together, those were the reforms which effectively reduced massively the waiting lists. Of course, there was extra resources. The only criticism I would make of Lord Patel is that he referred to Tony Blair's promise of 6% increase per annum as uncosted. It wasn't uncosted. We'd costed it. We just hadn't told the Chancellor. That was the controversy of that. So as I've said, with each reform there was great political controversy. My final point is, thereafter there is a mystery, because you would assume that after the Labour government left office, the Conservative governments that come in consecutively would not only adopt those practices, but would turbocharge them. But in fact, they dropped them. They disappeared. They disintegrated, apparently, until last year. And I pay credit to the Minister who's replying today, because he was one of those who pushed for the readoption of these. But I think the lessons of those 5 things are very important for any future government, and hopefully will be taken on board by a future Labour government.
My Lords, like the noble Lady Keithley, I also was thinking this morning as I was reminiscing about the number of NHS debates I have taken place in since I came here 20 years ago. Well, it's at least one a year, and I gave up counting when I got to 20. And the tenor of those debates has got more and more depressing. We have had words of wisdom that I've heard several times before, and particularly I'd like to mention the noble Lord Hunt of King's Heath, who really always gives a characteristic, brilliant overview of what needs to be done. I would disagree with him and the noble Lord Reid about whether the Blair years' injection of money and reforms, they certainly did improve things for a short while, but they were never continued, not during the Blair years itself, nor indeed afterwards. And of course, one of the problems with central government control, which we've had, is that you have no history. Nobody remembers the next Department of Health enthusiasms come along. There is no history remembered by one set of ministers after another. So to witness what has happened to me over the last 20 to 30 years, having been first employed in the NHS when I was 17 as a healthcare assistant, been through the whole gamut of levels of interest and worked alongside the NHS, I find it personally utterly heartbreaking. I really think it is no more amount of money throwing it at the NHS will do anything to improve productivity, generate a workforce proud to belong to the NHS, or produce a quality of care to rival the best in the world that we aspire to, nor to change the chronic defensive culture, which is disastrous. We do have the skills, we have the talented people, and we waste them by profoundly inefficient human and capital infrastructure. The NHS is dying. It's rather like dentistry has died in the NHS, more or less. The NHS is also dying bit by bit. I was shocked when I was admitted as an emergency last year to a District General Hospital in East Anglia at the quality of care and the ongoing support that was provided. I really thought it was appalling. It is not a badly rated hospital. I understand that now up to a quarter of young people in London, 19 to 24, cannot bear to be treated like they are by trying to get a GP appointment, so they go online and pay 39 quid for an online GP appointment, which sees them on video instantly, and they get a prescription the same day. That is something that is going to happen more and more unless we really do something. Of course, the last 13 years of organisational model, with no one able to make any serious decisions, endless time wasting, has made things a lot worse. But we still have this centralised system which has not changed since 1948 and which gets worse from time to time. Question in March, I think it was Lord Markham who answered the question, about the decision to concentrate children's services at the Evelina rather than the Royal Marsden children's cancer services. I have no axe to grind, don't know either of those institutions. But my overwhelming sense was Lord Markham should not have called in that for another decision. He should have said, or looked at it again, he should have said, let the NHS managers who've made this decision get on with it. The sooner we get our hospital providers out from underneath, the better. The model where we have everybody in the provider system and everybody in the funding system controlled by central government works in very small countries only. Luxembourg and Iceland both have our system, works quite well. After many years of having a raw, sensible system, the Canadians adopted our system and their health services gone steadily downhill with increased waiting lists, people not getting the central funding from federal government they need, and indeed it doesn't work. When are we going to accept that we need to develop a model where the providers and purchasers are separate? I've gone out of time, so I'm just going to end with my hope that the next government, of whatever colour it is, will get to grips with the need for profound reform and include social care, of course, as well in the reform which is necessary.
My Lords, I'd also like to thank Lord Patel for the debate and congratulate Baroness Ramsay on her outstanding and so moving maiden speech. As we've already heard today, public satisfaction with the NHS has fallen to an all-time low. But despite this, there is still strong support for its three founding principles: free at the point of delivery, primarily funded through taxation and available to everyone. Last year, the King's Fund published a report on NHS performance compared to 17 other OECD countries. Essentially, it was a scorecard, and that showed that on the plus side, NHS performs well in protecting people from some of the catastrophic costs of falling ill, and had a relatively low share of the UK's health budget was spent on administration. Some might be surprised at that. On the minus side, they concluded that the NHS had fewer key resources than its peers, below average health spending per person, and specifically had fewer doctors and nurses and less equipment such as CT and MRI scanners and less hospital beds. In addition, it said the NHS performs noticeably less well on outcomes such as survivable cancers, treatable mortality and life expectancy. Now, various independent commentators have concluded that changing the funding model is not the primary answer, nor, of course, is it either desirable or feasible to always just pour more money in. The important thing, as the Health Foundation has argued, and I concur, is to get the current NHS model to work better, i.e. reform the way it works. The key, surely, is to increase capacity in the right places. So simple to say, so hard to do. It's indisputable that funding growth is skewed towards the acute sector. Despite the majority of daily NHS activity happening in general practice and the community, a large proportion of expenditure on health and social care goes towards acute hospital trusts. Now, the answer to overcrowded hospitals, in my view, is not simply more hospitals. The health and care system must be radically refocused, as Lord Patel and others have said, to put primary and community care at its core if it is to be effective and sustainable, and people can get access to the GP, to a pharmacist and a district or mental health nurse. And this was one of the key findings of the Select Committee on Integration of Primary and Community Health Care, on which I had the privilege to sit, so expertly chaired by the Noble Lady Baroness Pitt-Keighley. The committee found a lack of communication, coordination between the everyday primary and community services relied on by people using the NHS, and that was leading substandard care, missed opportunities for home or community-based treatments, and the overstretched hospitals were put under even further strain. I want to turn now to productivity. My Lord's, respected health commentators have been looking at what has been called the productivity conundrum. A recent Institute for Government report found that despite increased spending, much of which has been going on increased staffing numbers, there hasn't been a resultant rise in productivity if measured against metrics such as the number of patients treated. We really need to understand why this is. The report drew particular attention to the fact that most hospitals are running at above full capacity, they don't have enough beds, and it's estimated that each day around 13,000 beds are occupied by people who don't need to be there but can't be discharged because of lack of community and social care. We all know that after years of neglect and underfunding, our social care system is in crisis. Secondly, despite notable increases in the headline numbers of staff, the NHS is losing too many experienced employees, and they're being replaced by junior staff who are naturally less experienced and need more support. Staff burnout, low morale and pay concerns are cited as principal reasons here. And a recent ISF report also concluded that whilst it's difficult to measure productivity, the NHS is less productive now than pre-pandemic, particularly in hospitals. It was at pains to say this wasn't about staff not working hard, but pointed the finger at Victorian estates, too few diagnostic machines and outdated IT systems causing communications problems within and between hospitals. My Lords, I believe there should be far greater focus on retention and making the NHS an attractive place to work, and that should be central to the NHS workforce plan, and we need a plan for the social care too. If not, we will never clear the backlog or reduce waiting lists. We also know, finally, that valuable NHS equipment and operating theatres too often stand idle in the evenings at weekends. Can the Minister say what plans the Government has to address this, and whether it might include bringing in independent clinical teams from outside the NHS, a point raised by Lord Reid? And finally, are we going to see a productivity plan to set out how the productivity increases announced in the spring budget alongside the 3.4 billion additional capital investment will actually be achieved? In my view, Parliament needs to be scrutinising these plans.
My Lords, I thank the noble Lord Patel for securing this debate. It's a pleasure to follow my noble friend Baroness Tyler, and I do commend the noble lady Baroness Ramsay for her excellent maiden speech. I welcome this debate's focus on health and social care. And in this regard, I pay tribute to the noble lady Baroness Warwick for her speech. Too often, social care is considered in public debates primarily in the context of ensuring that the NHS is not overwhelmed. This debate's title is rightly ambitious about social care reform. But given the current state, social care simply needs to be there when people need it, in a comprehensive, timely and affordable way. This was highlighted by the case in Newcastle of Dr. Jo Wilson, who had been diagnosed with dementia in 2020. Following her death in January 2023, her husband Bill, who had provided round-the-clock care as a result of inadequate and consistent care support, described the care system as broken. There are also many cases linked to poor dementia care, particularly accessed for loved ones of those under care, raised by campaigns such as John's campaign itself, founded 10 years ago. The Archbishop's Commission on Reimagining Care developed a vision for social care, drawing on Christian theology and values. The Commission heard the need for a fundamental shift in how social care is thought about, organised and delivered. It proposed a national care covenant, a process initiated by government in dialogue with stakeholders to clarify the responsibilities of everyone, individuals, families and communities, alongside local and national government. What assessment does the noble Lord the Minister make of a covenant as a means of rebalancing social care roles and responsibilities? Areas prioritised by the government in recent years are worthy of attention. We do need more digitisation of systems and databases. We certainly need more care workers and an attitude shift around that work's importance, reflected in pay and conditions, as other noble lords have mentioned. Indeed, the greatest challenge the sector faces in delivering high-quality care and support nationally is workforce recruitment and retention. The North East is no exception. In 2022 to 23, the vacancy rate was 8.7%, with 6,400 vacant posts. My Lords, I commend the newly published report by the think tank Theos that considers the intersection between love, work and care. It offers a different and profoundly helpful lens for valuing care more highly. It says, love is a skill. It is what makes care possible. The lack of a shared sense of why social care matters may contribute to attempts at reform being abandoned. With the health and social care levy scrapped, the cap on costs delayed, there lacks a long-term strategy around funding social care. My Lords, I worry that neither this debate nor the fundamental debate about the value and purpose of social care is taking place. It can feel as though there is a collective burying of heads and a desire to avoid the next NHS crisis, rather than recognising that the success of our health and care systems are fundamentally bound up with one another. Where is the vision? Social care demands our focus, not as an end in itself, but as the very means by which we can begin to experience life in all its fullness.
My Lords, may I too congratulate the noble Lord Patel for his very wise words in introducing this debate. I would expect nothing less, and may I say what a pleasure it was to hear the maiden speech of Baroness Ramsay. I'm sure we'll hear more from her. The excellent library report for this debate suggests that there may be little benefit in seeking new ways of funding and new systems of delivering the NHS. I was reminded of Maynard Keynes, the economist, who said, well, not only should any proposed change produce some improvement, it must be sufficiently better to make up for the evils of transition. And we've seen plenty of evils of transition over the years. But I want to focus on one specific set of problems amongst the many that need attention. The difficulties faced by patients coming to hospitals have been well rehearsed. Crowded emergency departments, queues of ambulances waiting outside, long waiting lists for patients needing to be admitted, cancelled operations. The list is endless. And I'm acutely aware of them as someone who has spent most of his working life in hospitals. But, my Lords, if there are to be any solutions, they must be found outside hospitals, in the community, where social, community and primary care are hardly coping under their loads. And it is there where the problems for hospitals and for everywhere else arise. When Age Concern noted that there were 700,000 elderly patients attending emergency departments because they couldn't get an appointment to see their GP, when over 15% of acute hospital beds are occupied by patients waiting sometimes weeks to get out of hospital, and when patients wait so long for care in the community that they are much iller by the time they reach hospital, then it's little wonder that the hospitals are overwhelmed. So I make no excuse for focusing on the problems in the community, as other noble lords have, that they've been accumulating for very many years. Local authority funding has been squeezed to a point where they are clearly not coping. And because almost two-thirds of their budget is spent on social and community care, these are being cut to the bone. And now we have far too many vacancies for health visitors and district nursing posts. Meals on Wheels have disappeared and support services are squeezed out completely. Yet demand for social care is increasing. There were almost 2 million requests to social care departments in 2023, and waiting lists are growing. Some wait many months for assessments, and when they get to the front of the queue, they have to go through a tortuous and bureaucratic process that few can understand. It's a two-stage system, as others have said, an assessment of whether they really need support, and secondly, an assessment of whether they can afford to pay. Few can understand it, and few can pass. Then there is the problem faced by the very large number of people who are cared for at home by relatives and friends. Many such carers give up paid employment to look after their relatives, and if they apply for help, and if they can get through the mountainous bureaucracy, they may be able to receive £76.75 a week. Ludicrously low recompense when it's recognised that this huge number of independent carers, several million of them, are saving the Exchequer vast amounts of money. Surely we can do better than that. Finally, I want to shine a light on what I think is a disgrace in social care, and that is the way we treat our social care staff. We treat all NHS staff badly, but care staff are at the bottom of the pile. They are not only the poorest paid employees, who can earn much more in many jobs outside caring, but they're also treated badly for the vital role they play. They don't have a nationally recognised training programme or a qualification that is approved and registered. A lack of a professional qualification and the prospect of career progression causes many to leave caring within their first 12 months. 10% of jobs are vacant, that's some 165,000 vacancies advertised now, and high sickness and absentee rates are far too common. The picture I have described has been creeping up for years, and my questions for the noble Lord, the Minister, are: will he look again at how we can make the careers of care home workers sufficiently attractive so that we can retain them as well as recruit them? Will he press for them to have professional qualifications after recognised training programmes and the prospect of career progression? Will he reduce the distressful level of bureaucracy faced by applicants for social care? And if there is any more money going at all, and quite large amounts were being bandied about last year that have not yet become visible on the ground, if there's any more money around, it should be focused where it will have most impact, that is, community and social care.
My Lords, it's a pleasure to take part in this debate, and I, like everyone else, thank Lord Patel for introducing it so brilliantly, and I also congratulate Lady Ramsey on a really, really good maiden speech. This is an interesting week in that we have decided that we are going to put a ban on kids smoking. What we haven't put a ban on, and in fact what we are encouraging, is kids eating an appalling diet. We are flooded with unhealthy foods, which is incredibly heavily advertised in all media. I mean, and you just have to look at sport and look at the Olympics when it comes along this year. The most healthy thing, it's going to be McDonald's, it's going to be Coca-Cola everywhere. And yet we are worrying about our NHS. We have to start having the conversations with the food industry, because if we don't, the NHS, which we all treasure and love, is going to creak under the strain. I have lots of alarming statistics. I'm not sure which ones to choose in the next 4 minutes, but here's one. Before the year 2000, there were no known cases of children in the UK having type 2 diabetes. There are now almost 10,000. All of those children are going to be on the NHS books for the rest of their lives. They are also going to be ill. They are also not going to, let's look at it purely economically rather than compassionately about what kind of life they're going to lead. They are going to be not working, not paying tax, not being good parents, not contributing to their society. We can change this, but we have to start. It amazes me. I've been doing food politics for nearly 2 decades. We have very, very little involvement with the national health. We have very little involvement with doctors when you talk about what you can do. Do you know that the reason why most children go into hospital and have general anaesthetics, no, all under 10, it's to have their whole teeth out. That is because of the food they eat. We are also the lowest country in the world for breastfeeding. I have just seen my daughter, who has twins. She managed to feed them for over a year. She had no help. She had no support. I was astonished by the advertising she received from companies calling themselves Hungry Baby and stuff like that, absolutely trying to get under a mother's skin and say, get off feeding on the breastfeeding and get them onto these formula foods, which have higher sugar levels, which set your sweet spot higher for the rest of your life. It's outrageous. There's almost no regulation going on. And as for support to help with breastfeeding, this is a young woman who had twins. There was nothing. We paid for consultations to help her get through it and to help her achieve that. So is it any surprise that our kids are growing up to be the most obese in Europe? And in fact, as a country, we're now the 3rd most obese in the year. No medical professional doubts what obesity does to our society. What they fail to make the connection with is back to the food companies. Sticking again with the with the baby food companies, I mean, all these little pouches that they sell, not only do they cost a lot of money, they're extremely addictive to the kids because they're nice and they're handy and they convince mothers that they're doing the best thing for them. But in fact, they are the root cause that starts them eating too much sugar. So in some way, you could say that the staggering profits that are made by the food companies every day, the NHS is paying for this. We're paying for this from our money and from the lack of the care that nurses and doctors are able to give people who are, I'm not saying these people aren't genuinely ill, they are ill, but they're ill from a preventable cause. And in the same way that the government has had the balls to walk up to the tobacco countries this week and say, actually, you know, I know it is more complicated, I can see the minister looking at it, of course we have to eat, but there is a big difference between what we eat and how we eat it. And we are just machines like everything else, and we need to put good stuff in the machine. And I would really welcome that, you know, I unlike my colleague here, had an extraordinary experience in the NHS. I managed to scald my foot. I got a blister the size of a tennis ball. I ended up getting sepsis, and I was in the burns unit in Bristol. It was impeccable. However, in the lobby, Costa Coffee, Friends. In the Friends, not one single piece of fruit. It was cakes, biscuits, all the way. I got transferred to the Chelsea and Westminster outpatients. Again, the treatment was impeccable. Down in the lobby, bloody Costa Coffee, donuts, long queue, in the French shop, not even a grape. I mean, we have to start looking at this. As I say, no one would buy a Rolls Royce and put Coca-Cola in the engine and expect to go 100 miles down the motorway. We are not dissimilar. We are even better than a Rolls Royce. We deserve to put better stuff in. It's time the whole NHS and the country got this one straight.
My lords, it's a delight to follow Baroness Boycott. She's certainly got a different view on things. I'd like to congratulate Baroness Ramsay of Warheath. It was a tremendous maiden speech, and she brings great experience to this House, for which I'm sure we'll be very grateful. I was particularly struck by her comment on reorganisation, and I want to return to that later. We've had too much of that and a little less performance. I'd like to draw attention to my interests, which are in the register. Lord Patel made a tremendous opening speech. I think it was very knowing. It was very clever the way he went across the whole spectrum of things. I am perhaps a little less Olympian, and I'm going to focus on one or two more narrow things. Modern high-performing healthcare systems, my lord, are characterised by high quality, high productivity, critical, consistent, predictable funding, and that leads to high patient satisfaction. And it is being done in other parts of the world. And for patients, that means access, rapid diagnostics, timely care, rapid discharge, preferably to home. And how's that delivered, my lords? Well, it's delivered by putting the patient through a seamless journey along the continuum of care. Nowadays, that can be AI-enabled, but what it has to have is an IT system that sits behind it to provide the single view of the patient. It's siloed. And it's very hard to deliver integrated care, and I'm sure Noble Lady Baroness Giffey knows this, unless you've got a data system that gives you that access. So in other countries where this has been deployed, we've seen diversion away from hospital, something many noble lords have commented on. Between 20 and 40% of people just don't need to go in, and they need to be treated in other places. So actually an encouraging thing is the National Health does get things right sometimes. The Integrated Care Boards stand a chance of delivering this. But we have to focus and get on with it, and it's going to take 5 years, but it needs to be done. But in the meantime, my lords, we have to actually operate what we've got a lot better. And the key to that is really going to be a number of things. Really getting the primary care contract fixed, getting healthcare professionals facing up to patients much more on a substitution basis, and streamlining the back offices of primary care. These are simple things, they're managerial, but they're critical. Acute hospital productivity has got to rise. And I think Noble Lord Reid talked about it. Why did it take us so long? And perhaps the Minister can answer this. Why did it take us so long to go back to payment by results? In a system that's desperate for activity, we went to block contracts. I mean, it's as close as lunacy as you can get. So can we go back to payment by results, and can we broaden it to encourage more providers
And so we get diversity of provision, but also we get diversity of location. We need to move it closer to the patient. And the only way to do that is create certainty of payment through the tariff system. So I think those are the straightforward things we can do. Two things I suggest we do. I've talked about payment by results. The second is, can we just simply face up to the issue of delayed discharge? And what we need to do, many other countries do, the National Health Service needs to pay for the first 60 days post-discharge. It cuts it all out, gets the people out of the hospitals, and it's a very straightforward solution. It's got to be paid for at some point. Better it's paid for and the argument's moved out to somewhere else while people consider how to fund it. Long-term care funding, social care funding, I think is for another day. But, my lords, no healthcare organisation can actually be efficient and deliver high quality if it's got appalling staff morale.
Yeah.
44% of those, and only 44% of those employed in the NHS on the last staff survey, felt valued.
Yeah.
That means 56% didn't. 25% felt bullied.
Yeah.
25% by their colleagues or the managers. Most health systems, if it got to 5%, they'd have the drains up. I mean, this is absolutely hopeless. So really what it comes to is we have a management problem, my lords. We've had a lot of strategies. We've got great strategies. But actually the management problem, and again, the government sort of, ministers knew what to do, so they commissioned the Messenger report. And the Messenger report was absolutely tremendous. 9 things we can do to fix it. Perhaps the minister can tell us if those 9 are going to be implemented, because it's 2 years since it was published. And my lords, if we don't get the management right, then actually nobody's going to put any more money into it. And just a little anecdote, my lords, I'm just quick on time. If you have a group of NHS managers and you ask them to name the 20 best run hospitals in England, you get the usual. You get Northumbria, you get Chelsea and Westminster, despite the diet. Okay, you get Leeds, and you get South Warwickshire. People can do 8 easily. If they're lucky, they do 10. At best, they do 15. My lords, there are 135 hospitals in this country. What does it tell you about the depth of management? And so the critical thing, if this is to work, and I'll now shut up, but the critical thing is to get the NHSE working properly. I'm not sure I'd be as dramatic as the Lord Warner, but we have to actually face up to the fact we have not got a working management system. It's Soviet. And we're way past Soviet times, my lords. Let's hope we can preserve and save the NHS to be free at the point of delivery.
Fantastic.
My lords, I pay tribute to Lord Patel and his tireless work for the NHS, and as Lord Carter said, your sort of Olympian view across the system that you gave us earlier, and I too will only focus on 1 or 2 things. I'm very, very glad that the Messenger report has been mentioned, and I'd like to repeat that question to the Minister, because it is 2 years since it was written, and Gordon Messenger, who's someone who served in the army, does actually know how to run a system. I'd want to talk very briefly about 2 things that are beyond hospitals that other people have already talked about. One is prevention and one is social care. Just briefly on prevention, to echo some of what Baroness Boycott said, my simple question to the government is, when will they fully implement the 2015 obesity strategy written under the Cameron government, which included, for example, broadcasting bans on unhealthy food? That's a very simple question to answer. I would have thought it has now been quite a long time since that report was written. On social care, I was intrigued by something Lord Patel said, which I hadn't expected him to say, which he spoke warmly about long-term care insurance. And I thought I'd just take my cue from that and talk a little bit about that. We have seen in the past few years many interesting proposals for better funding of personal care. We've seen the CAP, which was led by Andrew Dilnott, which is due to come into force in 2025, but on which I note there is spectacularly little activity. And I actually think there's an opportunity now, post-COVID, with a public who are much more aware of the value of social care than they were before COVID. I do think this has become a politically salient issue in a way it wasn't before, because so many people have seen what care workers really do, how many of them really stepped up to the plate. We saw people moving in with older people into their homes, into the homes of disabled people, leaving their own families, putting themselves at risk. And I think that made a big impact in a way that it hadn't before, because the truth is that you don't understand what social care is unless you are in receipt of it or a relative is in receipt of it. So the vast majority of people in this country still don't really know what it is, but what the polls do show is that people are increasingly aware that it's complex, it's patchy, and it's deeply unfair. And people are increasingly prepared to say, yes, we do need more money, but we need a new look at the system. I think, as others have said, the single-payer system for the NHS is the right answer and the only answer, and I don't think that should be reopened, as Lord Patel said. But I do think there's an opportunity to look for a different model for social care. And in terms of the long-term care insurance point you made, if you look at Germany or Japan, which are two countries I've studied in depth, they spent several years having a deep conversation with their voters about a long-term care insurance system. It's slightly different in each place, in which everybody pays something in and everybody is able, if they need it, to take something out. And that is a simple, it is a transparent, and it is a sustainable approach that we don't have at the moment. At the moment, what we see is battles over continuing healthcare where the primary health need is not defined. We see 40% of care home residents paying all of their own fees and cross-subsidising other people with less money. I could go on, but we are all aware of the depth of unfairness in the current system. And I would simply like to ask the government whether it does have any plans to look at other possibilities beyond the simple cap on care. One of the reasons I think why Andrew Genomic, who is a great man, is so frustrated and why successive governments have not implemented the policy is that it is very hard politically to describe a cap to people which is not a cap. It doesn't actually cap the bed and board costs. If you imagine being a politician and going out on the doorstep and trying to sell people what is ostensibly a cap on what they need to spend, and it's not, it's very, very hard to deliver that. The other issue is it obviously would help people facing truly catastrophic costs, but it would only help really quite a relatively small number of people. And therefore, I think there is an opportunity to have a much bigger and wider conversation, but it would mean, I'm afraid, going to the heart of an issue which is dear to the heart of many voters in this country, which is the question of their primary asset. Would they be prepared and should they be made to sell their home to pay for care? I note that Boris Johnson changed his language on this over time because he, as everybody does who looks at this issue, discovered that you can't actually get a sustainable funding system while making no claim whatever on the homes of people who, yes, have saved to buy that home, but yes, may also have been lucky that the home value has increased. So I would just like to ask the government whether it would consider or has any plans to consider looking at that alternative to the Genomic cap.
The NHS is neither a leader nor a laggard, as told in a comparative study of several countries. And I think that broadly captures what many of us feel about what the NHS is doing. It embodies some fine values, such as equality of treatment, free at the point of delivery of service, strong incentive to regulate expenditure, maintaining the self-respect and confidence of individuals that when they are in trouble they will be looked after, they don't have to worry about payment. I mean, all these are great virtues which NHS embodies. But also, sadly, it is a product of its time. And if you cast your mind back to 1948 and what follows afterwards, one begins to see an authoritarian culture where the experts know what is best. This is the ethos that is embodied in the culture of the NHS. So that, for example, you can have a long waiting time and people don't say anything wrong about it, or you have no choice of consultants whom you will go and see, or of doctors, it's decided for you, or your path to the consultant is already heavily guarded, and it's not something that you can choose. Also, there is a poor investment in staff and diagnostic technology, so that you have got MRIs and machines and CT scans and other things lying idle because they are only supposed to be used during working days. So for all these reasons, we have reached a situation where the NHS does a lot of good things, embodies a lot of good values, but also does a lot of work which many of us regret. The question, therefore, is it needs to be improved radically in some respects. And the question is not simply how can we maintain its sustainability. The question is, in its current form, do we want to sustain it? What are the changes we want to see made in it? And can those changes be sustained over a period of time? So my own thoughts on this I want to share very briefly. We cherish, the British people by and large cherish NHS, but not uncritically, which is why increasingly when they begin to discover the defects of the NHS, they become critical of it. 24% of the people heavily alienated from the NHS, and many more increasing. And that's something which should be a source of concern to those of us who value the institution. So how do we maintain? What are the funding that should be done for the NHS? And there we have relied on the taxation as the source of revenue. And I think it's absolutely right that we should do so. I don't have the time, but I would want to argue that compared to, for example, the social health insurance or the personal health insurance, taxation is a much better way. It gives the individual a sense of ownership of an organization. He feels that this is his organization because he has paid for it, and so on. But naturally, taxation is subject to party conflicts, party divisions, and it's never going to produce enough. Therefore, the money that revenue that taxation brings has to be supplemented from revenue in other sources. But what are the other sources available to us? And there are two. One is how do we reduce the cost, and how do we increase the income of the NHS? Now, if you look at the reduce the cost, one can think in terms of a variety of ways in which the expenditure can be cut. Lots of work being done on why medicine, for example, that patients have are lying unused, used for a day or two while the ailment lasts, and then they are completely forgotten and eventually wasted and thrown away. Now, there are ways in which you can use electronic technology to alert the patient that this is the time for him to take his medicine. So there are various ways in which you can control that. Also in terms of raising a revenue. I was told by several people who have worked in this area in the United States and elsewhere, why don't you have a research scholarship so that you have people who work with NHS providing abundant data, the state having access to all these enormous people, enormous diseases. Why don't you have research done on this, resulting into innovations of tablets, medicines, instruments, which can then be marketed? It's not utterly impossible for the NHS to think in terms of research scholarship. So I should have thought that there are ways in which the NHS's revenue can be increased, its expenditure can be decreased. And this is something which is the goal towards which the British public itself seems to be moving. The NHS being based on the principle of mutual solidarity, but also introducing into it the principle of personal responsibility.
Good. I was a doctor 55 years ago next month, just across the river at St Thomas's. Much has changed since then, some good, some bad. I applaud my noble friend Lord Patel. I agreed with his powerful opening speech. As well as personal suffering, there's huge economic cost when the nation becomes less healthy. And we've heard that there are more than 2.6 million working-age people out of the labour market due to long-term sickness. Huge cost to the Treasury in additional welfare and healthcare support and lost tax revenue. Yes, the NHS needs more investment, but it's not just about that. I think it's about changing the health and social care offer and improving access and equality of access and changing the balance between hospital care and care in the community. Italy closed its public psychiatric hospitals successfully, investing in 24/7 community provision. The Royal College of Psychiatrists asked that the next government commits to a new health infrastructure plan for mental health, with one aim of improving the therapeutic environment of mental health and learning disability and autism in patient settings. But it also hopes for real investment in expanding psychological therapies in early intervention and in public mental health. My Lords, the impact of negative press about the NHS and about social care has an impact on the morale and mental health of staff and the confidence of patients. But this affects staff retention. A recent survey of 3,154 doctors by the General Medical Council found that 13% of respondents said they are very likely to move abroad to practice medicine in the next 12 months. A further 1 in 3 said it's very likely they will move abroad at some time. This points to 4 key areas for improving retention: workplace conditions, pay, career structures, and the perceived ability of our healthcare system to meet patient care needs. Healthcare is a different and more complex service than when the NHS was founded in 1948. Individualised medicine is here to stay. There are more treatments available, some very sophisticated and expensive. There's more bureaucracy, and we live in a more litigious world. The demands and expectations of the public have increased. My Lords, I read with joy an NHS pamphlet from 1948 which outlined to the public what they could expect from the NHS and, importantly, what the NHS could expect from them. I will quote a few gems from it. And in my first quote, do notice mention of mental health. You will be entitled to all forms of treatment in general and special hospitals, whether as an inpatient or as an outpatient. These include, for instance, maternity care, sanatorium care, care of mental health, and all surgical operations. And about dental care, it says you need no application form, just call by appointment on the dentist of your choice when you need him. All necessary fillings and dentures will be supplied without fee. If you want anything especially expensive, you will pay the cost yourself. And maternity services, it will be the doctor's responsibility with a midwife to give the proper care, and if he considers it necessary, always called by the midwife to be present at the confinement. How wonderful it sounds. My Lords, perhaps we need an NHS pamphlet for 2024 to relaunch a new contract between the public and the NHS about what can be expected on both sides. Central to solving the problems, and I suggest that actually, as well as maternity care, that we should have palliative care added to the 2024 pamphlet. But central to solving the problems facing the NHS will be transforming social care from a safety net for people in vulnerable circumstances to a relational system that enables people to flourish. The endless gatekeeping, signposting and managing demand within the NHS all contributes to the increased demand and greater complexity of social care. And the bureaucracy affects unpaid family carers too, as I know only too well. Kate Garraway recently said about her experience of being a carer, "If I have any regrets, it's every minute that I didn't spend holding his hand because I had to go and write an email, make a phone call, fight the system that should be there to catch you when you fall, but feels when you're going through it, it's there to catch you out." Long-term thinking, long-term funding and more consistency so that everyone, staff and patients, know what to expect. My Lords, care needs to move away from glamorous, expensive interventionist hospital care and spend more in the community. And if this doesn't happen, more expensive hospitals will need to be built to manage people's acute needs that could have been better prevented or better managed.
My Lords, I should first congratulate my noble friend Lord Patel on securing this critical debate and raising such challenging questions. Unlike many of today's speakers, I am not a healthcare expert, but as an entrepreneur, employer and advisor to SMEs over the last 30 years, I have developed a particular interest in the health and productivity of our workforce. So I will start with the dismal subject of economics, as the long-term sustainability of the NHS hangs on the state of our public finances. My Lords, I sit on the Economic Affairs Committee, as indeed does the next speaker, the Noble Lord Davis of Brixton. And our current inquiry is also on the subject of sustainability, not of the NHS, but our national debt, which at £2.7 trillion has grown eightfold in just over 20 years. On current trajectories, neither the financing of our national debt nor our National Health Service can be considered sustainable. Ever since the financial crisis 15 years ago, the UK has suffered from a low-growth deficit economy. We consume more than we produce. That's an economic and health issue. The growing obesity burden being just one sign, inactivity another. Our tax revenues cannot keep up with our expenditure on public services. So we routinely resort to borrowing, an additional £100 billion or so added to the debt pile each year, to the point where last year's interest payments on debt at £120 billion was only 30% less than our entire NHS budget. And demographically, we have double trouble, an ageing population with falling birth rates. Our workforce has ceased to grow in spite of immigration, while the proportion of dependents is escalating. So without gains in productivity, there is no real economic growth and no increase in our tax base, on which NH funding entirely depends. This week's data from the ONS makes grim reading. The number of long-term sick off work has in fact hit a record high of 2.8 million, an increase of 700,000 in just 3 years. So with an ageing and growing population, the demand on NHS services continues to outstrip our economic growth. So unless health tech or AI comes to our rescue, the next administration faces the prospect of raising taxes further and borrowing more. So what can be done to break this cycle? My Lords, we must prioritise healthcare for both the long and short-term sick who have the potential to join or rejoin the workforce. Following COVID, we now have a mental health pandemic, the biggest single factor behind the escalation in economic inactivity, and yet the NHS is just not resourced to cope with this surge. There are many other conditions and disabilities that come up high on the list of causes of economic inactivity, where waiting lists are growing or treatment is inadequate. These include musculoskeletal conditions, which have risen by 30% over the last 3 years, a reflection perhaps of an increasingly sedentary lifestyle. And of course, neurological disorders, which affects 11 million of us in this country, myself included, is very high on the list and deserves far greater focus and resourcing. The UK, shamefully, has the lowest proportion of neurologists across Europe and the second highest mortality rates. Indeed, The Economist estimates that in this field, the consequential damage of healthcare resource by non-specialist care, plus the social and economic burdens, is costing the UK £96 billion per annum. So against this figure, can I ask the Minister how much of the current NHS budget is devoted to treating neuro, as I cannot find any reliable estimate for this figure. Thanks to the Migraine Trust, I can share the data for just one of the most common and treatable neurological disorders. The NHS devotes some £200 million to the treatment of migraine, a condition which causes £5 billion in costs alone in lost working days, one example of a serious mismatch. My Lords, we must make much greater effort to align the NHS with the economy, for sustainability is a two-way street.
It's a pleasure and
an honour to have been able to listen to this debate, and I'm happy to come in at this late age and add some additional thoughts. Thanks to Lord Patel for initiating debate and all the other speakers, and particularly congratulations to my noble friend Baroness Ramsay of Wall Heath. Now, one of the things that arises from putting your name down to speak in this sort of debate is you get a large number of briefing notes. Now, I can't claim to have read them all. I would ask the noble Lord the Minister, perhaps he should commit himself to have read all the briefing notes and to acknowledge the contribution that they've made to our debate. A consolidated version of the notes, I think, would be a useful document. But given the volume of material, there's obviously bound to be much that's missed from our discussions. Now, I want to focus my remarks on good mental health, and I thank in particular and would urge people to read the briefing notes both from the Royal College of Psychiatrists and from the Mental Health Foundation. In the time available, I can only touch on some particular points arising from their submissions, but I think they're important and should be read. I want to make three main points. First, the considerable cost of poor mental health. I want to emphasise that we are measures available to us that can tackle those problems. Now, providing healthcare isn't just about the financial return, but when we can expend relatively limited amounts and get huge benefit, we clearly need to take that into account. And in that respect, the focus has to be, in this area, on prevention. The value of measures aimed at prevention is considerable and will be effective across the whole range of the health service. And thirdly, I want to mention the importance of undertaking more research, particularly in the area of mental health. Now, of course, I will take the opportunity to urge again the importance of getting a Mental Health Act through the House. We presumably will now await the next session, and I think an incoming Labour government, if we have one, is committed to doing that. The problem is that the problems assessed by Sir Simon Wesley now 6 years ago are still there, and the Act is a sort of symbol of the intention to deal with those problems which he identified. Now, what measures could we adopt? What are the measures that we need to think through? Well, they're all set out in the submissions, and there's not enough time to go through them all. I think workplace, the issue of poor mental health amongst the workforce has been mentioned, touched on already, and that's where you can get, according to the research which we've been provided, you can spend £1 of expenditure, we are told, provides us with £13.62 in improvements. And this bears directly on the overall health of our economy. Individual health is very much health as the economy as a whole. The 118 billion that poor mental health is costing us, that's 5% of GDP, is an obvious and clear target for work to be undertaken across the important area of poor mental health.
The noble Lord Patel for this timely debate. My Lords, my colleagues and I at the Bromley by Bow Centre have been at the cutting edge of innovation in primary health care for 35 years now. We entered this space by accident following the tragic death of a local resident, Jean Viles, in an East End housing estate in May 1991. Jean's death led to a senior-level inquiry at the London Hospital, which picked apart not only the lives of an East End family in very challenging circumstances that had been badly let down by the NHS and its siloed culture. The inquiry also challenged the NHS on its lack of attention to detail, its management systems and culture, which had forgotten who the customer was. Sound familiar? We were told at the time that lessons would be learned. Well, 35 years on, I can assure you few lessons have actually been learned by the NHS. Indeed, my GP colleagues tell me that getting upstream and creating more integrated responses to health needs gets harder to do, not easier. In the course of this well-documented and tragic encounter, we began to realise that in poor communities at least 70% of the determinants of health are social and not biomedical. They have nothing to do with doctors. The NHS business model was absolutely the wrong way round, and there was a desperate need to get upstream into the prevention agenda. Our practical response, as an increasingly entrepreneurial culture took root in Bromley, was to build the first working model of an integrated primary healthcare centre that moved beyond just health and social care and embraced housing, employment, business, the arts and education, etc. We have created 97 businesses with local people over the years. We started to join the dots. Even with the support of the then Prince of Wales, now the King, this work was done against a prevailing culture in the NHS that talked about innovation but rarely grasped the nettle. Today, the Bromley by Bow Centre is responsible for 55,000 patients on 4 sites and is being taken nationally through the Well North programme, which I lead, and I declare my interest. The centre today hosts 2,000 visitors each year from across the world. All this work and learning, but so little in practice, has actually changed. One hospital medical director we work with described the NHS as a blancmange when it comes to innovation. It wobbles when innovative ideas and practice are first introduced, but always returns to shape and form. My lords, this is not a sustainable culture. So what needs to be done? Here are 7 brief steers based on many years of practice. Firstly, stop treating the NHS like a religion and be honest about its condition. It is ill and broken, and business as usual is not an option. It needs radical surgery over a 10 to 20-year period. Secondly, we need cross-party agreement to stop the constant meddling of countless politicians and endless restructuring. I was involved in the 2012 Olympics programme for 19 years from day one. Our focus was on creating a real legacy in East London from a once-in-a-lifetime opportunity. We focused early on gaining cross-party support for a 25-year programme. Go and have a look at the results. Fourthly, thirdly, take seriously Dr. David Haslam's concern that if we carry on with the present NHS business model, it will absorb 100% of the GDP by 2070. It's not sustainable. We are creating a dependency culture. Fourthly, create a learning by doing culture and move away from so many expensive, outdated reports that few actually read. Fifthly, the modern world is about people and relationships, not processes, so nurture them at all levels of the NHS. 6, technology is not the answer to everything, but it is a fantastically useful tool. Start small, interface the technology with people and their practice, and use it to grow organic cultures that work. Stop trying to land big solutions from above. 7, my lords, we have always found right across the country individuals and localised groupings that were able to deliver this more joined-up entrepreneurial approach. At the moment, this is true, for example, in Bradford, York, Rotherham, East London, amongst others. However, they are not in general supported and encouraged, and thus the approach does not become established more broadly. As has recently been observed, the NHS has more pilots than British Airways. Why not just get behind these good people long term and build a culture based on innovation, integration and entrepreneurship? My question to the Minister is this, and to the opposition if they were to come into government. Given the present spending trajectory and business model, what percentage of the UK's GDP does the government estimate that the NHS will soak up by 2070, and what is it doing about this challenge? Who in the department is thinking about this problem?
I normally don't put my name down to specialist debates like this one because I'm not possessing the necessary expertise. And that's certainly true for this debate, although during the last 2 hours, my lords, that I've learned a lot. There are, however, 2 reasons why I wish to address your lordships. Firstly is to recall the foundation in 1948 of the National Health Service, one of the 2 great social reforms of the Labour government of 1945 to 1951. The other being legal aid, which alas has now almost withered altogether away. And my lords, I was only 10 years old in 1948 when the National Health Service was introduced, and I remember it very well. My lords, the second reason why I wish to speak is because I believe we should understand the current challenges of the National Health Service and praise the National Health Services for its success. And that has certainly, to some extent, come out in this debate. It's touching to remember the National Health Service was designed in its origin to save money for the economy amongst almost to the point of being financially self-sufficient. My lords, where are we now in this debate? If I may boldly summarise, as a speaker at the very tail end of the speeches, where I think we are. The first is that since 1948, we've had the benefit of the provision of more and more techniques, wonderful techniques, which has helped us and helped us well in health. But the problem has been that we have needed for this more and more expertise and more persons to operate these techniques. The result is that there are more and more specialists among doctors and among all of those who give their support to those doctors. For example, there are nurses now highly skilled and highly trained in specializing, for example, in oncology, supporting the doctor oncologist. Similarly, there are radiographers supporting the doctor radiologists in the great range of scanning, MRI scanning and so forth, which is now available. The result is that lots of things are being done and have been done much to our benefit. If I may speak of my own personal experience, referring to heart treatment, my lords, that 50 years ago there was no open heart surgery and no use of stents. My father died when he was 60. I have the same heart condition. I had a large bypass operation 30 years ago, and I'm standing now before your lordships. There are that I think we should recognise there are lots of people in the National Service who are working very hard and doing well. I'd just like to cite one example of that, and that's the website that the guys in St Thomas's Trust have set up. I happen to be a patient of that trust, and the website has set up what they call My Chart website, and it's easily accessible and provides an awful lot of very, very important information you need as a patient, amongst other things, when is your next appointment date. My lords, I therefore end my short address to your Lordship, and it's in this way. I believe we should always give praise to the National Health Service, and I invite the Minister to do just that when he stands to speak. There must be planned an all-party alliance to decide the future of the National Health Service, which is a point that has been very well made in this debate.
I join in congratulating and thanking my noble friend Lord Patel for introducing this very topical debate, and also join in congratulating the noble Baroness Lady Ramsay on her very moving maiden speech. As a last to come to the crease before the closing speeches, I'll be very brief and just make a few observations. I came to this debate not as a medical expert. I do, like my noble friend, suffer from peripheral neuropathy. But for the past 20 years, I've been a company doctor, fixing companies both large and small, and not in all occasions helping them become more efficient and more profitable. My first observation of the NHS is the apparent failure of effective leadership. I know many GPs, specialists and junior doctors. One junior doctor that I spoke to yesterday commented that he had been on strike not just because of the money, but because he and others felt disenfranchised. We live in an exciting time of digital transformation and artificial intelligence. We're seeing huge advances in quantum computing. By analysing vast amounts of medical data, including electronic health records and genetic information, we can uncover patterns, predict outcomes, and improve diagnosis treatment. But ultimately, the focus must be on effective, on adaptable and accountable leadership. There is a danger that many of the medical fraternity are too focused on following protocols rather than guidelines and get bogged down in red tape. I recently read the book 2030, The Future of Medicine by Professor Richard Barker, a specialist on longevity research. I should just at a side point mention that my noble friend Baroness de Souza is just having her 80th birthday today. Happy birthday to you. Although 80 in your lordship's house is but a youngster. The observations that Professor Barker made when he wrote this book in February 2011 pertains as much today as it did then. In essence, he called attention to the need to re-architect the NHS and provide more effective time management to NHS GPs. Many GPs complain that they spend far too much time on administration and far too little time using their medical skills to diagnose and treat acute conditions. In this regard, a lot of elderly patients are not getting the treatment that they need and deserve. One of his observations was the need to focus on preventative medicine. My lords, we have seen huge advances in oncology, in cardiology, but a lot more can and should be done on preventative medicine, including more focus on tackling obesity, gut health, and lowering cholesterol. The noble Baroness Lady Blackwood spoke very eloquently on the profound impact of genomics on personalised medicine. With the ability to sequence entire genomes rapidly and affordably, we are entering into an era where treatments can be tailored to an individual's genetic makeup, making it far more effective and targeted therapies. My lords, time precludes me from debating the need for more effective procurement within the NHS. A huge amount could and should be done to save costs with shared services. I agree with my noble friend, Lord Kaka, that the long-term sustainability of the NHS is a joint effort and requires commitment from all stakeholders, from government, healthcare professionals, patients, and the public sector. Can the Noble Lord, the Minister, when winding up, advise us as to what measures have been taken to conduct a global best practice study on the long-term sustainability of public healthcare? And I agree with my Noble Lord, my friend Lord Warner, he made on the excellent suggestion of simulating the Singapore healthcare system. So in conclusion, there are a lot of positive developments in the NHS, and they should be congratulated and appreciated for their hard work. But my call is a simple one. We need to focus on effective and adaptable leadership, on effective procurement, and on patient care, and continue to focus on prevention. More funding in the NHS does not necessarily solve the problem. We need to get smarter.
My Lords, I'm very grateful to Lord Patel for this opportunity and for the reminder of the coalition government, which I think we might accurately describe as the last sustained period of strong and stable government that we had in this country. And it's a moment to remember the work actually done by my friend Norman Lamb, who I think was recognised as an excellent Minister for Mental Health and Care. Some of the other things that the government did, well, essentially the good bits are ours and the bad bits were theirs, including the pointless NHS reforms, and that's all we really need to reflect on with the coalition government. I've enjoyed hearing a wide range of interesting contributions, including those from my noble friends, Lord Scriven and Baroness Tyler, and I was also very moved by the excellent maiden speech of Baroness Ramsay of Wall Heath. I share with her having 2 children born in St Thomas's Hospital that, unlike her, I didn't have to do the hard work. I was a mere spectator. The area I want to focus on is not to cover the issues where other people have applied their much greater expertise, but to talk on an area where I have some expertise, and that's around the role of information technology, which I think has become universally recognised, including in this debate, as a key enabler for the kind of productivity increases we need to make the NHS sustainable. And to Lord Kaka's call for areas where we could have cross-party work, I think this is one that is particularly conducive. I'll be very interested, actually. I don't really care who's in government, and I think most geeks don't care who's in government. We have a phrase which is code wins arguments. Unfortunately, elections don't work that way, but in the world of code, if you design a better product that runs more quickly, that's the one you should implement. And I think there is a large community, actually, of people out there who believe in the NHS, who have those technical skills, who would apply them, who don't care who's in government, and would apply them. And I'd ask the Noble Lord Minister to reflect if that's not one area where we could make immediate progress in terms of getting a non-partisan approach. I also didn't want to talk about the whizzy cutting-edge technology, which is something we often go into, but just to think about some of the foundational elements where some of the biggest gains could be realised, and could be realised quickly, because there's a large amount of low-hanging fruit. And there's sort of 5 areas I wanted to raise with the Minister, which essentially form layers that together would be a platform for improved services. First, we need a comprehensive catalogue of the collection, storage and use of data across social and healthcare systems. That doesn't exist today. Again, I think it's something that Lord Carter-Coles referred to. We just don't have that comprehensive catalogue, and so we have enormous inefficiencies built into the system. There's a natural tendency when you're building technology to look at the shiny front end, to look at the app, but the front end is only useful if you've got the back end set up properly. And in the case of NHS and care, that's frequently not the case. It's the boring bit, but it's essential that we walk through and audit all the many systems that we use and document the data that we have. I'd also add that openness here can really build trust. If people out there can see who's got what data, what they're using it for, actually that openness is what you need to generate trust. When people see it as a black box, that's where the trust dissolves and where people start to withdraw their consent. So that open database is essential. Along with that, I think we also need a lot of openness around the processes and around the tools that are used to work with that data. And actually these days, a lot of the code can be open. You can make the code reusable. And I think we could reasonably aspire to get to be in a position where a new entrant into the market could essentially say to service like ChatGPT, here's the data model, here's some example code, here are the processes, build me a system. And that's where we'll get the increased competition in areas like GP systems, which have come to the fore these days. There's two major suppliers, and people say, well, why aren't there other suppliers? We could make it a lot easier for people to come in and not only compete on cost, but importantly, compete with innovative features. And we do that by making sure you've got the data model open and by making sure that the processes and other areas and the code base is open. The third area is, once you've got all that foundation sorted out, is thinking about the content and the messaging. And again, there's a very current debate around the fact that, you know, online platforms like TikTok, they're really, really good at getting people to engage with them. And we see that as a devious and dangerous behavior. Well, actually, that's what we need in the NHS. When you're running a screening program, you want the kind of skills that get people to click on the screening program and sign up for the appointment. And actually, I thought we saw some of that with the encouragement for COVID vaccinations. But there's a hell of a lot of other communication that we get from the NHS that isn't of that quality. And it's a real waste if you're going to set up a screening program not to have the kind of skills you need. Software engineers are not the people to write this stuff, by the way. And a lot of the stuff we get looks like it's written by, it's my profession. It's not people like me that write it. There are really, really good people who do that, who know how to get people to engage. And that's, again, what their health service needs. As a sort of general maximum, I mean, it seems to me that the kind of systems we use to engage with our healthcare should be at least as good as the ones we use to share cat videos, because I think the healthcare ranks a little bit higher in importance. But the gap we can all see is enormous at the moment. The fourth area is around ownership. Committees don't own things, named people own things. And again, if you look in the tech sector, when you want something delivered, you say to somebody, here's your target, you need to deliver this product. You often working in a massively matrix organization, you need to get lots and lots of other people who don't work for you to deliver the product. But the person who's tasked with delivering the product, you need to know who that person is and not allow it just to be put into a committee where everyone can pass the parcel. And it requires persuasion, support, and crucially a service culture. And I was interested in the comments from Lord Hunt where he said, you know, people hate NHS England. And that's a real problem. If NHS England is signing up and buying services like the Federated Data Platform, and it's got to roll them out to this massive variety of organisations. Some of them are brilliant. Some of them, there's two IT support people who are busy trying to help people change their passwords. And you come along and go, can you implement the system? Well, they can if someone helps them to do it. So we need somebody somewhere to have that kind of services culture, somebody who owns it and then has the tools to say, look, I need to get that trust to implement this system. And the way I'm going to do it is not just to send a directive out. I'm actually going to go and hold their hands and help them and find out what the barriers are. I don't care what they are. I'm going to address those barriers. And the fifth element is, again, it's come up in discussion today. It's around the integration with other systems. I sometimes feel there's a kind of nervousness around talking about stuff that's outside of the NHS. You know, increasingly, people are doing that. It was referenced in the debate today that people might be consulting an online GP service. You know, we have these sort of negative phrases like worried well. Well, actually, I think it's quite nice to be a little bit more worried about your blood sugar level, about your diet, about lumps and bumps where we shouldn't have them. There's a range of things we should be worrying about, and we have opportunities to get tests done. But there's very little integration between all of that and the core NHS. And that's something that we could fix. It's one way, again, to make it sustainable, that we are paying in many cases, either ourselves or our workplaces are paying for health checkups. Once we've collected that, again, if the system's right, let's get that integrated in. And we have systems like Patients Know Best, which are trying to do this. We've actually paid for, but they're not universally rolled out and they're not in universal usage. To sort of pull all that together into an example, if we think of something really boring and old-fashioned like blood pressure checks, which Lord Patel rightly raised as a key way of stroke prevention, if you had a standard sort of data model for how we deal with blood pressure checks, if you had standard code for how anyone, doesn't matter whether you're collecting on your phone or in a private clinic or wherever you're collecting it, a standard way to put that into your record, if you had an owner of a blood pressure screening program whose job is to get 80% of the target group to get screened once a year, don't care how you do it, just be creative, figure out what's the right way. Is it text message? We don't care as long as you get that 80% in. And if you had that integrated, that person's job is to hustle, to hassle, to help people, to work with all the providers of mobile phones and the workplace networks to get it done. That's the kind of thing that can make a difference. So I hope that's helpful to the Noble Lord the Minister to kind of describe, I think, a model that could be applied more generically across a lot of the challenge areas that the NHS faces to get us from a position where I do think at the moment a lot of people know what good looks like, they know what they want, but the structure itself kind of militates against it because responsibility is too distributed and there are too many people doing individual separate things in silos. And the only model I think we have at the moment to overcome that is a directive from NHS England. And that's not what you need. You need this detailed grunt work on the ground to get us from where we are today to where we want to be, which I say is either as a patient or as a staff member in the NHS, please give me systems at least as good as those which we use to share cat videos.
My Lords, I would like to start by congratulating the Noble Lord, Lord Patel, on securing this debate and, of course, for introducing it with his characteristic authority, insight and care with which we are so familiar in your Lordship's house. And I'm delighted that my noble friend, Baroness Ramsay of Wall Heath, chose this debate to make her excellent maiden speech. How proud her mother and father would have been of her today, and what a difference she made to the life of her late sister and indeed to the National Health Service, and what a difference I know she will make to your Lordship's house. My Lords, to give some context to the need for long-term sustainability, over the last 14 years, as we've heard, the Health Service has acquired the undesirable distinction of having the longest waiting lists, lowest patient satisfaction and the worst strikes in the history of the NHS. And the Noble Lords, Lord Patel and Lord Kekar, not only described the harsh realities and the inequalities of the current systems, but also asked what all parties would do about correcting it. And I am indeed flattered to be invited to give some flavour of what an incoming Labour government, if there is to be such a thing, would, how it would approach the challenges ahead. I'm glad indeed on this point that my noble friends Lord Hunt and Lord Reid and the noble Lord Crisp recognised the positive impact on the health of the nation of the last Labour government, in which I had the honour of serving as a public health minister, which allows me to say to noble lords, including Lord Bethel, Lord St John, Baroness Boycott and Baroness Finlay, that when it comes to prevention and a focus on the broader improvement of health, I'm totally signed up. And my noble friends Lord Hacking and Lord Parrock have brought a welcome analysis to the debate today. And I want to agree with my noble friends Lord Hunt and Lord Turnberg and the noble lady Baroness Hollins that on the workforce, bullying, burnout and pressure is no way to retain or to get the best out of people. We only have to talk to people in other sectors to remind us of that. Now, this change will require a change in culture on so many levels, and the noble Lord Crisp, spoke of the fundamental need for shared vision, hope and energy, and it struck me that that is exactly what is missing at present in health and social care. And to social care, which is indeed, as we have heard today and so many times before, it is inextricably linked with the health service. There are, and I would remind any incoming government of this, including a Labour one, there are a number of first-rate and considered Lords reports, including on social care, primary and community care, and long-term sustainability. And therefore any government will be extremely well advised to delve into them. And Wes Streeting, Shadow Secretary of State, has been very clear about the measures that need to be taken on social care, and has emphasised the need for long-term planning, long-term thinking and funding. The Right Reverend Prelate, Baroness Cavendish and my noble friends Lord Turnberg and Baroness Pitt-Keithley and Baroness Warwick were absolutely right to speak of the invisibility of unpaid carers and the poor treatment of employed care staff. This, my lords, is not sustainable.
Neither are the record levels of sickness and long-term conditions which affect the workforce, which my noble friend Lord Davis and the noble Lord Lonsborough have spoken about so clearly today. My Lords, I don't consider myself a technological expert, but I do consider myself a technological convert, and I'm sure the noble Lord Allen will be very pleased to hear that. And so I've looked to countries like Israel, which I believe to be at the cutting edge, which is where the UK needs to be. At the emergency department at the Sauraski Medical Centre, people register digitally. They identify themselves through facial recognition and measure their own blood pressure, temperature and heart rate in self-triage booths. Patients are given a barcode and a number is sent to their phone, which they can track on a screen. The most serious cases are seen within minutes, and virtually no one waits more than an hour. And last month, this Tel Aviv hospital became the first in the world to integrate an AI chatbot into its triage process. And what is the driving force behind this? This Israeli hospital is designing healthcare around the needs of the patient, as my noble friend Lord Carter and many other noble lords called for today. And sadly, this is in very much of a contrast with Britain, where our NHS reels from crisis to crisis, whilst the political debate circles around funding, staffing and pay. Yet the way that we bank, shop, travel and work has been digitised in the past decade, and yet the NHS remains outdated. There are multiple IT systems within the NHS and no requirement for being interoperable. I can't even say that. Let's try. Very well. You know what I mean. What it means is that systems can't talk to each other, sometimes even within the same hospital, let alone between institutions or between primary and secondary care. There are at least 21 different types of electronic patient records in hospitals and 34 apps to book an appointment. No company would be able to survive with productivity like this, something that Baroness Tyler referred to. So let me ask the Minister, how has the government allowed it to develop like this? The NHS England's digital lead, Joe Harrison, estimates that for every pound spent on technology, it generates between £3.50 and £4 in savings. Such an approach makes sound financial as well as good health sense. So whilst the case for reform is overwhelming, too often the innovators are thwarted by a fragmented system or vested interests. So could the Minister say what is being done to overcome this? We know that an estimated 13.5 million hours of doctors' time is wasted every year due to inefficient IT. Fixing that would be the equivalent of 8,000 new doctors joining the NHS. That is the difference between the huge staff shortages that we see, and yet it could fill almost every vacancy for a doctor. And with our country's population ageing, the health of the public worsening, and chronic disease rising, the sustainability of the NHS is indeed crying out for change. My Lords, I recently went to see the National Theatre's production of Nye, as I know that many other noble lords have done. And when he created the NHS in the 1940s, Nye Bevan had absolutely no idea of the scientific revolution ahead. And regrettably, if we dropped Nye Bevan into the NHS today, he would see the modern-day pressures of an NHS that is overly hospital-based and gets to patients too late, at greater cost and with worse outcomes. So if Labour does go into government, we will arm the NHS with the modern technology it needs, doubling the number of scanners and putting AI into every NHS hospital so that patients are diagnosed earlier. We will get rid of the unnecessary bureaucracy whereby innovators have to tout their technology to each individual NHS trust. And we would stop the need to sign separate agreements with each of them. And we'll streamline the route in for innovators and put the entire NHS in partnership with the technology and life sciences sector. And my lords, following the pandemic, over 32 million of us carry the NHS app in our pockets. That gives the potential to transform how the NHS interacts with patients, can promote good health and increase people's control over their own healthcare. We would make the NHS app not just something to assist the NHS in healthcare, but as a key component in delivering care, both preventative and curative, and to empower patients. And finally, my lords, what do health and care leaders want to see? They know that investing in primary and community care results in lower demand in hospital and emergency care. For every pound invested in the NHS, £4 comes back to the economy. The greatest economic returns do come from investing in primary and community care, where we see a £14 economic return for every pound invested. If Labour is to be in government, this is the step change we will make.
I would like to also thank Lord Patel for bringing this debate today, and very happily start off answering Lord Hacking's question by praising the NHS. But I think the very ethos of the debate that Lord Patel has brought up today is, as critical friends, we know that we need to look at the challenges that the NHS is facing if it is going to be sustainable for the next 75 years. I would really like to welcome Baroness Ramsey. I enjoyed her journey. I shared some of her difficulties about finding her way around this building. But I think I hopefully sum up the views of all the House that we're delighted that you found your way to be with us here today and generally in the Lords. I would also like to thank all the noble Lords for the constructive way that this debate has taken place. And again, I praise Lord Patel by the way you framed this whole debate to bring that about. And you know, there were a lot of very thoughtful contributions, and I think we built in many ways on the debate that actually Lord Scriven called about 6 or 9 months ago, and I think it was very much in keeping with that. I think I particularly enjoyed, I must say, the passion that Baroness Boycott brought to it all. I thought at this age I probably shouldn't declare an interest in Costa Coffee, which I don't have, by the way. But no, the passion thought through, and I enjoyed. You know, there were very many thoughtful contributions, which I hope I will be able to build on. But particularly, if I may single out some of those thoughtful contributions by Baroness Murphy and Lord Warner, which I hope I will build upon. I want to avoid this being a political debate. I would say, maybe contrary to some of Lord Hunt's points, actually we're seeing similar challenges across all 4 NHSs, across all 4 nations. And perhaps I might say that maybe the worst performing of those by the records that many noble Lords will remember, whether we're looking at waiting lists or a number of records, I'm afraid to say that was Wales. So I think it's challenges that we are all facing at this point, but what I want to do is to unite in this debate in terms of looking at the positive way forward. What I do recognise that many noble Lords brought up, including Lord Hunt, Lord Warner and Baroness Murphy, is about the over-centralised nature of the NHS. And what I would disagree with Lord Hunt on, though, that is from direction from ministers. I think the whole point that we've tried to set up in terms of the ICBs, as referenced by Lord Carter, is to actually reverse that and put more power at a local level. They're early days in their life, but we definitely see that as the way forward. And I hope in this to answer the points made by Lord Kakar and I think Baroness Cavendish in terms of trying to make this into a long-term conversation. I freely accept that probably at this part of the political cycle we can only have so much of a conversation. But from my part, whichever role I may or may not be in post-election, I will give my undertaking to take part constructively with whoever is in power in what I hope will be a constructive conversation, because I think it does need to be the sort of environment where, as Lord Allen says, code wins the argument, and there's people coming from all around and can have those sort of constructive conversations. But I think that will include, as Baroness Hollins says as well, a new contract between the NHS and the people, and what that involves. I'd like to start off, though, by really echoing some of the financial realities that Lord Bethell brought up, and Lord Mawson and Lord St John. The reality of the situation is that we're spending about 10% of our GDP right now. It's going up as a proportion year after year, and it will only go one way. And at the same time, no one is proposing major injections of cash. Again, I think we all recognise the financial situation. The proposals, for instance, that Labour made amount to less than 1% of the NHS budget. So I think what we can all unite on right now is this is not an argument about pumping in lots more money, but it's about finding other ways to try and make the NHS more sustainable, using, I think in many ways, as Lord Warner says, a tough love approach where that is appropriate. And so what I want to try and talk about is the things we're doing in terms of the infrastructure and capacity, as Baroness Murphy mentioned. When I say about infrastructure and capacity, I'm talking about the labour supply, productivity plan, the capital estate. And I also then want to combine that with the new ways of the way we need to engage, whether it's around technology, whether that's around prevention, or whether that's around primary and community care, which from my minds are the ways that we create a sustainable NHS going forward. So starting off with the labour supply, I completely agree with the point that Lord Hacking made, that the staff are at the heart of every successful organisation. That begins with making sure that we've got the right number of staff. That's what the long-term workforce plan is all about, trying to make sure we have the proper recruitment and training and long-term resources. But more important, I think, really, than any of that is some of the points that Baroness Hollins was making about retention, and Baroness Finlay in terms of the right culture that people live in, that they feel that they're valued and they're caring and they're in a supportive environment, rather than all too often we've seen in terms of often a bully environment. So, to Lord Carter and Baroness Cavendish's question, I think the Messenger report is vital in terms of answering this. But the role of management is fundamental. And again, I did a lot of work, particularly when I came into this, to Lord St John's question, really trying to look at hospital performance. And I did all sorts of analysis of it, and looking at demographics in a local area and the relative funding and all sorts of things. And it didn't matter what I did, there was always at least 50% unanswered in terms of when you try and do your multiple regression analysis and everything else like that. And the conclusion I came to, probably not really earth-shattering, is that 50% performance is all about the management and the leadership and the culture that's driven from that. And I think a lot of that is allowing people through that, as Lord Kokar was saying, allow people to work at the top of their profession. And if you allow them to work at the top of their profession, then that's when they can make the new developments and the new innovations. What that does mean is, using technology and AI to help reduce administration. And I'll come on to that more in the productivity plan later on. But there's also some more uncomfortable conversations in terms of using other staff to do some more of the administrative parts. And again, I totally support and welcome and appreciate both Lord Hunt and Lord Scriven in some of their moves they make in terms of the use of things such as physician associates, where it's really to try and take away a lot of that burden, so doctors really can practice at the top of their profession in terms of doing that. And in terms of the productivity plan, firstly, to Baroness Tyler's point, yes, that needs to be put and is being put into a detailed plan that we can all review be round about July, where we have the opportunity to do that. But it is, as Baroness Merrin said, it is absolutely identifying that we need to replace the inefficient, amongst many things, the inefficient IT estate. It is doing a lot of the basics in terms of the PCs and the Wi-Fi and all the things that I know Joe Harrison very well, work with him every week, all the things that he mentions. And it is about systems and EPR, but it is actually arming the staff and clinicians with the basic equipment so you can start small, as Lord Mawson referred to. And those are the things, as well as electronic patient records and the FDP, that we will get those sort of productivity improvements. And when I talk about, you hear numbers like 35 billion, I'm talking about increased output. I'm not talking about savings. I'm talking about how we can get increased treatments and output from it all. And definitely by using things mentioned by Lord Reid and Lord Calter, by payment by results, by the right incentive systems, and as Lord Crisp said as well, by the use of the independent sector to supply where relevant. Vital to all of this, of course, is the capital estate, and that's why the new hospital plan is a very vital part of this. The work that we've seen that is if you put the right digital instruments into a place and the infrastructure into hospitals, we know you get 10% more productivity. If you put the right real estate in, then actually a combination of real estate and physical estate, you get 20% productivity and output to some of Lord Warner's questions. And that's not just output in terms of time, but that's also reductions in terms of length of stay. And we all know the sooner you can get people home in terms of length of stay, the more likely that they can go on and live successfully in their environment. To the points made around adult social care by the Bishop of Newcastle and Baroness Warwick and Lord Turnberg around the training qualifications of the staff, totally agree with that. That is what we are trying to do. We have now for the first time actually introduced a qualification that adult social care staff can get in training, where we've actually put on 18,000 different adult social care providers into a system now where they can put up training and get easy managements of payments of it all. But I think there is more long-term work that needs to be done in terms of having a fundamental funding model, to the points raised by Baroness Warwick as well, and Baroness Cavendish, that will involve a covenant of care. But I think, in all honesty, we need to do more work in terms of long-term funding solutions. I can't say enough about prevention. I think Lord Bethel said to me, very simple, your speech today, prevention, prevention, prevention. So a few more things than that, but I will definitely add a few preventions in terms of all of that. The whole long-term workforce plan and productivity plan is designed towards that. The whole screening programme that we're doing is absolutely Chris Whitty's biggest concern, is that simple things like blood pressure that was missed during COVID will now lead to excess deaths in heart disease. And so, as Lord Patel mentions, those simple blood pressure measures and midlife MOTs are fundamental to what we're trying to do on it all. And I will definitely take Lord Allen from your book, because I think it's absolutely right. You really need the champions in that space to do it. Dental, I totally agree with the points made by Baroness Boycott in terms of the importance of dental in this and the early checkups needed in terms of the prevention agenda in all of that. That's what our new plan is about, the school checks and the water fluoridation, all to try and help on that. And I see a future world in this, and I'll talk more later on, that you get much more of a targeted screening programme. So in addition to our midlife MOTs, which are blanket programmes, AI really needs to be used to help target screening so that we can really help people in terms of that prevention. I totally agree as well, and I think it's something that none of us have solved, is the ever-increasing use and funding towards acute hospitals. And all fundamentally agree, as raised by many noble lords here, the need for to rebalance that towards primary care and community care. I look forward to Baroness Pitt-Keithley's and the committee's report on the integration of it all and the pointers we can learn from that. We have managed, I think things such as Pharmacy First are good ways ahead. You know, we've seen 98% of pharmacists sign up and already 125,000 consultations. I think the dental plan, we've had 500 new dental surgeries, which is a 50% increase in the numbers taking NHS adults. But I think we do need the new model of care mentioned by Lord Scriven and Lord Chris, away from the acute hospital, as Lord Thornburg says, into care and community. And I can't speak more highly than the Bromley in Bow and the visit I did to, you know, Lord Mawson should be very proud of everything I saw there. That's probably of all the visits I've done in the almost 2 years I've done this job. That's one of the ones that I enjoyed the most and was most impressed, and saw that was a model that we really needed to take going forward. And really, as part of that, they're doing exactly what Baroness Chisholm mentioned in terms of looking at the whole health of the person and really seeing how they can really care for them in the community. Of course, that does require the community nursing as part of that, which my mother was one of, and so I realised the ability on that. It does need to be all backed by technology. I'm very proud to say that I've been responsible for the app for the last 18 months. We've gone from 10% of people having their medical record to over 90% right now. We have 33 million people, as Baroness Marin said, who now use the app for things like digital prescriptions, their medical records, and appointments, to the point that Baroness Pitt-Keithley had an example of just the other day. We do need to broaden it out so more people you realise all the features that are there on the app, but we really do see the app as the front door to the access to the NHS, and that it will lead to futures in future therapies, whether it's musculoskeletal that many normal lords have mentioned, or whether it's mental health, that gives the opportunity for it all. And to Lord Parrath's point, I really believe that actually the app does allow people to take control and take the power away sometimes from the experts always, and give them the control to put the power in their own fingertips to do that. Data and AI are fundamental to this, to absolutely enable the sort of precision medicines that Baroness Blackwood mentions, and I thank her and all the work that Genomics England are doing to really lead, and I know it is an institution that we need to rightly be proud of. That is the future of medicines, but it is all underpinned by the data that's there. I actually, funnily enough, have kicked off a cataloguing of that, because that is fundamental in it. In the adult care space, we've actually increased digitisation from 20% to 60% in quite a quick period of time. But all of this, having the data at the heart, will actually allow the competition and the innovation to take place. But we need to make sure that conversation happens in the right way, so that we do bring the public with us on that journey. So I think, again, I hope that gives a vision of the things that we're trying to do in terms of both putting the infrastructure in place, the supply of workforce, the technology infrastructure, the IT and the capital, but also accompanying that with the new ways of working, whether it's absolutely focused on prevention, it's absolutely more input into primary care and community care, but really using AI and technology and genomics to lead the way forward. I think we will all agree that's the only way that we're going to get a sustainable health service going forward. So at that point, I would like to thank Lord Patel and all the contributions to this, and I'd like to thank the spirit of the debate and the thoughtfulness that has gone on. Special thanks again to Baroness Ramsay for choosing this debate for her maiden speech. And thanks to Baroness de Souza for joining us on her 80th birthday. For it, I'm honoured. As ever with the time, I apologise to those that I haven't managed to cover completely in my response, and as ever, I promise to have a thorough wrap-up of it all. But once more, I would like to thank the Noble Lord Patel for this debate and all the participants in terms of the way forward.
My Lords, the new rules don't allow me to speak at length, so I'm constrained. I truly am constrained, because I would have loved to dissect out some of the speeches made by some of my friends. And I wish the hospital in wherever it was had treated the noble Baroness Murphy better, because her speech might have been different. My Lords, when I bid for this debate, I did not imagine that I would get the talent pool that we got today of the brilliant speeches that we made. None other than the top of the list, of course, is the maiden speech by Baroness Ramsay of Wall Heath, and we look forward to hearing her over and over again. I had intended that this will not dissolve into a political debate, and I'm glad that it did not. And I'm glad that my challenge to all the three benches paid off. By the way, Lord Allen, it was this House that won the vote to put mental health at equal esteem. It was not the other House, although the Minister Norman Lamb did help. It was an amendment by Baroness Hollins that won, although I had to call it because the noble lady wasn't here at the time. So, my Lords, I thank you all again and grateful that you all joined this debate. It had lots of ideas, but the key things that came out is the need to make community and primary care stronger. The second one was the solution to social care and its funding, whichever way we go down. And the other was the data. By the way, as you were speaking, Lord Allen, I asked ChatGPT, how can data help healthcare? And it produced immediately a 700-word 6 points that I might send it to you. My Lords, thank you.
The question is that this motion be agreed to. As many as are on opponents shall say content. To the contrary, not content. The contents have it. My Lords, we'll just have a couple of minutes for the front benches and everybody else to change places. Started. So the motion for debate now is the number of children and young people being committed into the care of local authorities. Lord Laming.
My Lords, I am